Welcome to your practice question review for the HESI Fundamentals exam. Every question mirrors the real exam. We break down why the right answer works, why the others fail, and the concept that connects them. Today's questions cover therapeutic communication, clinical judgment and prioritization, patient safety and infection control, post-operative and basic care needs, delegation, ethics and scope of practice. And don't forget, our website offers free exam guides and practice questions to help you ace your HESI Fundamentals exam. You'll find the link right down in the description below, so be sure to check it out and get everything you need to start studying smarter, not harder, today. So let's jump right in. Question 1. A nurse considers responses that block therapeutic communication. Some patterns shut down conversation or convey judgment. The nurse identifies the response that is non-therapeutic and would discourage the patient from sharing further. Recognizing these patterns is part of skill in patient-centered communication. Your options are A. Why did you let this happen? B. Tell me more about what concerns you. C. It sounds like this has been hard. D. What helps you cope when things tough? Which one is it? Pause the video if you need more time. The correct answer is A. Why did you let this happen? A is correct because why questions that imply blame are non-therapeutic and shut down dialogue. The phrasing puts the patient on the defensive and damages trust, leaving feelings unspoken and preventing further productive conversation in the encounter. B is wrong because asking the patient to share more is therapeutic and invites continued conversation. The technique uses an open-ended invitation that supports the patient in expressing concerns more fully throughout the conversation as it develops. C is wrong because reflecting the difficulty of the situation acknowledges the patient's experience. The therapeutic statement validates feelings and supports continued sharing without judgment or directive language at any point in the encounter. D is wrong because asking about coping strategies is therapeutic and patient-centered. The question respects the patient's autonomy and encourages exploration of personal strengths and resources rather than directing or criticizing the patient at any point. Therapeutic communication helps patients share thoughts and fears without feeling judged or rushed. Non-therapeutic responses do the opposite, closing the door to sharing, so learning to spot these blockers is often the real test. Hildegard Peplau formalized this idea in the late 1940s, arguing that the nurse-patient relationship itself is therapeutic. Patients in distress simply don't have the energy to push past barriers a nurse accidentally puts up. The blockers usually fall into a small set of patterns, while questions that demand justification, false reassurance that minimizes real concern, giving advice that strips away autonomy, changing the subject, and approving or disapproving statements that turn the nurse into a judge. Picture an older adult just told a biopsy result is concerning. Asking why they waited so long turns vulnerability into defense, while asking them to tell more about what's weighing on them opens the door to real conversation. Watch exam stems for phrases like blocks communication, shuts down, or discourages sharing. They signal this exact concept. When a patient stops talking, the nurse loses the information needed to plan care. Question 2. A nurse caring for an alert older adult must rank current problems. The patient has acute pain at 7 of 10, a low score on the fall risk screen, dry mucous membranes, and reports mild loneliness. The nurse uses the actual versus risk and ABC frameworks to prioritize. Your options are A. Mild loneliness while in hospital. B. Risk for falls based on screening. C. Acute pain rated 7 of 10. D. Risk for boredom during admission. Take a second. Which answer would you pick? The correct answer is C. Acute pain rated 7 of 10. C is correct because acute pain is an actual, current problem with a high rating that drives many other complications. Untreated severe pain affects breathing, mobility, and recovery, so the nurse addresses this real issue first now. A is wrong because mild loneliness is real but emotional and lower on Maslow than acute pain. The need can be addressed alongside other care once the more pressing physiologic discomfort has been treated and is decreasing. B is wrong because risk for falls is a potential problem and the screening score is low, suggesting limited urgency. Risk diagnoses generally yield to actual problems with active cues unless the risk is imminent and severe. D is wrong because risk for boredom is not even a typical priority diagnosis on a busy unit. It pales in comparison to severe acute pain that is actively impairing function and recovery for this patient right now. When several patients need help at once, nurses rely on structured frameworks to decide who gets attention first. Maslow's hierarchy ranks physiologic needs above safety, love, esteem, and self-actualization, while the ABC framework puts airway, breathing, and circulation ahead of everything else. Both exist because nurses cannot do everything at once, and because some problems threaten survival while others do not. The key distinction is actual versus risk. A problem that is currently happening, like severe pain, generally outranks one that might happen later, like a low-fall risk score. Consider a patient with severe pain, dry mucosa, a low-fall risk score, and reported loneliness. Pain comes first because it is current and severe. Loneliness is addressed next, and the full risk simply gets routine monitoring. Prioritization is not delegation or care planning. It is the upstream judgment about what matters most right now. When choices seem close, address the most immediate physiologic threat with the strongest active evidence. Question 3. A nurse caring for a post-operative patient with an abdominal incision considers the phases of normal wound healing. The nurse identifies the order of events. Each phase has a typical timeline and signs the nurse looks for, helping evaluate progress and detect any deviation from expected healing. Your options are A. Maturation, proliferation, inflammation, hemostasis. B. Proliferation, hemostasis, inflammation, maturation. C. Inflammation, hemostasis, proliferation, maturation. D. Hemostasis, inflammation, proliferation, maturation. Before I reveal it, which one do you think is right? The correct answer is D. Hemostasis, inflammation, proliferation, maturation. D is correct because the wound healing phases proceed as hemostasis, inflammation, proliferation, and maturation. The nurse recognizes each phase by its timeline and signs, supporting the patient with appropriate dressings and education during each stage of recovery. A is wrong because maturation is the final phase, not the first. The order described starts at the end and works backward, which does not match the actual physiologic progression of wound healing in any patient. B is wrong because proliferation does not begin before hemostasis and inflammation. The body must first stop bleeding and clear debris before new tissue can form. So this order misrepresents the actual sequence of healing. C is wrong because inflammation does not occur before hemostasis. The bleeding stops first. Then, the inflammatory phase begins to clear bacteria and debris. So the order in this option does not match physiology accurately. Wound healing follows a coordinated, predictable sequence of 4 phases, each with its own timeline and clinical signs that a nurse can recognize. First comes hemostasis, stopping the bleeding. Then inflammation, clearing debris and bacteria. Then proliferation, building new tissue through granulation, contraction, and epithelialization. Finally, maturation, where collagen remodels over months to years and the scar gains strength. The sequence isn't arbitrary. Uncontrolled bleeding ends the patient before healing can occur. New tissue can't form on a contaminated bed, and the body can't strengthen tissue that doesn't exist yet. Skipping a phase produces a failing wound, and lingering too long causes chronic problems like non-healing ulcers. Picture a surgical incision on day 3. Mild redness and thin drainage signal inflammation shifting into proliferation, not infection. By day 10, pink, beefy granulation tissue shows proliferation in progress. By month 3, the scar has paled and strengthened as maturation completes. Don't confuse wound phases with primary, secondary, or tertiary intention. Intention describes how a wound closes, but every wound, no matter how it closes, still passes through hemostasis, inflammation, proliferation, and maturation. Question 4. A nurse is preparing a high alert medication that requires independent double check per institutional policy. The nurse considers what an independent double check looks like in practice. The check protects the patient from errors that occur most often with insulin, anticoagulants, and similar classes. Your options are A. 2 nurses verify separately without prompting. B. 1 nurse double checks alone. C. 2 nurses agree without verifying steps. D. Verification can be done after dose given. What's your answer? Commit to one before I continue. The correct answer is A. 2 nurses verify separately without prompting. A is correct because independent double check means 2 nurses verify the medication separately, calculating doses and reading orders without prompting each other. The independence is the key safety feature, since a confirmation bias defeats the purpose of the check. B is wrong because 1 nurse alone performs a single check, not an independent double check. The whole point of the practice is 2 minds working separately, so a single check does not provide the same error reduction at all. C is wrong because 2 nurses agreeing without verifying each step is not a true independent check. Confirmation bias and time pressure produce errors when 1 nurse simply nods along without performing the calculation and verification themselves. D is wrong because verification done after the dose is given cannot prevent errors that have already happened. The whole purpose of the double check is upstream prevention rather than after the fact catch of an event already harmful. An independent double check means 2 clinicians separately verify a high alert medication, each reaching their own conclusion before the dose ever reaches the patient. The independence itself is the entire point of the safeguard. Studies show that when 2 people check together, socially, the second person often just sees what the first person points out. That confirmation bias is exactly why a shared or synchronous check fails to catch real errors. Mechanically, the first nurse prepares the dose alone, and the second nurse independently reads, calculates, and inspects the product without seeing the first nurse's work. Only when their results match does the medication proceed, and any discrepancy triggers a pause and a fresh look. This safeguard exists because certain medications have killed patients from a single uncaught error. Insulin, heparin, opioids, chemotherapy, and concentrated electrolytes are the classic high alert classes where independence matters most. Exam writers test the word independent, a nod, a shared glance, or a check performed after the dose was given cannot prevent harm. True independent verification happens separately and before administration, catching the error the first person alone would miss. Question 5. A nurse caring for a patient with a peripheral intravenous line notices the site is cool, pale, and swollen, with the infusion still running. The patient reports tightness at the site. The nurse considers the most appropriate first action upon recognizing this complication of intravenous therapy at the bedside. Your options are A. Increase the infusion rate to overcome resistance. B. Continue infusion and document the findings. C. Apply heat to swelling to reduce. D. Stop infusion, remove line, elevate the limb. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Stop infusion, remove line, elevate the limb. D is correct because stopping the infusion, removing the catheter, and elevating the limb addresses infiltration. The nurse applies a cool or warm compress per policy, monitors the site, and starts a new line at a different location. A is wrong because increasing the rate forces more fluid into the surrounding tissue and worsens infiltration. The action damages tissue and risks compartment syndrome rather than restoring proper intravenous flow into the vein. B is wrong because continuing the infusion despite swelling and pallor allows ongoing tissue injury. The findings are signals that the catheter is no longer in the vein, and continuing the flow harms the surrounding tissue significantly. C is wrong because applying heat to the swelling without first stopping the infusion does not solve the underlying problem. The fluid continues to enter the tissue while heat is applied, worsening the situation rather than resolving it. Infiltration happens when IV fluid escapes the vein into the surrounding tissue, usually because the catheter tip slips out or the vessel wall weakens. The pump keeps pushing fluid, but instead of entering the bloodstream, it pools under the skin. The hallmark signs are coolness, pallor, swelling, and tightness, along with flow that slows or stops even though the pump is still running. Patients typically describe pressure or aching rather than burning pain. The vein is a fragile tube, the cannula is a foreign object, and limb movement can dislodge the tip. Once the tip slips through the vessel wall, the pump keeps delivering fluid, which then pools in the surrounding tissue instead of the bloodstream. The correct sequence is to stop the infusion, remove the catheter, and elevate the limb before applying any comfort measure or starting a new line elsewhere, treating the swelling first, or increasing the rate to push past resistance. Only lets the tissue keep filling. Don't confuse infiltration with phlebitis, which brings warmth, redness, and a palpable cord, or with extravasation, which is infiltration of a vesicant drug that risks tissue necrosis. For all three, the first action is always to stop the infusion, then tailor the follow-up care. Question 6. A patient 4 hours post-operative from abdominal surgery reports incision pain at 8 of 10, refuses to ambulate, takes only shallow breaths, and is hesitant to use the incentive spirometer. The nurse must pick the nursing diagnosis most strongly supported by the gathered cues. Your options are A. Risk for falls related to surgery, B. Ineffective coping related to hospital stay, C. Acute pain related to surgical incision, D. Disturbed body image related to scarring. Which would you go with? Lock it in before the reveal. The correct answer is C. Acute pain related to surgical incision. C is correct because the cluster of high pain rating, guarding, refusal to ambulate, and shallow breathing all point directly at acute pain. The defining characteristics fit the diagnosis cleanly, and pain is driving every other finding. A is wrong because risk for falls is plausible, but no falls cues are present in this stem. Without unsteady gait, sedation, or attempts to climb out of bed, there is no support for naming this the priority. B is wrong because ineffective coping has no defining cues here, since the patient has not voiced fear, anger, or maladaptive behaviors. The nurse cannot assign coping concerns based only on a refusal driven by physical pain. D is wrong because disturbed body image requires statements from the patient about appearance or scarring, none of which appear here. The cues all point to physiologic pain, not psychosocial concerns about how the body looks. Acute pain after surgery is a defining characteristics-driven diagnosis, meaning it's supported by a cluster of cues, not one complaint. Let's look at how nurses build that cluster and match it to the correct label. The defining characteristics include a self-reported pain rating, guarding behavior, an altered breathing pattern, and refusal of activity, often alongside elevated heart rate or blood pressure, When these cluster together, the nurse names the diagnosis acute pain related to the surgical incision. Picture a patient guarding the abdomen, breathing shallowly, and rating pain 8 out of 10 near the incision. Each sign traces back to the same source, the surgical wound, which is exactly why the cues fit one diagnosis instead of several. Exam writers love tempting you with related but unsupported diagnoses. Risk for falls needs fall cues. Ineffective coping needs statements about fear or anger. And disturbed body image needs comments about appearance. And none of those cues appear here, so acute pain remains the only label the entire cluster supports. Chronic pain, anxiety, and ineffective airway clearance can look similar, but each has its own distinct cluster. When the cues point to a numeric rating, guarding, and shallow breathing after surgery, acute pain related to surgical incision is the diagnosis the evidence supports. Question 7. A nurse on a busy unit smells smoke and sees flames coming from a wastebasket in a patient's room. The nurse remembers the RACE acronym used in fire response and considers the first step that should be taken immediately to protect the patient before any other action. Your options are rescue the patient from danger first. B. Sound alarm before moving the patient. C. Try to extinguish the fire with water. D. Close the door and walk away. Don't overthink it. Which one feels right? The correct answer is A. Rescue the patient from danger first. A is correct because the first step in RACE is rescue, which means moving the patient out of immediate danger. Removing the patient from the room comes before the alarm, containment, and any extinguisher used during a fire. B is wrong because sounding the alarm is the second step in RACE and follows rescue. Pulling the alarm before moving the patient leaves the most vulnerable person closest to the fire, while precious seconds are spent on signaling. C is wrong because attempting to extinguish a fire is the last step in RACE and should never come before rescue. Water also is not safe on every fire type, so extinguisher selection matters too. D is wrong because closing the door without rescuing the patient first leaves the patient alone in danger. Containment matters, but only after the patient has been moved and the alarm activated to bring help. When a fire breaks out on a hospital unit, staff don't have time to think from scratch. They rely on RACE, a sequence that puts patient survival ahead of instinct. Rescue comes first, moving the most vulnerable person away from danger. Alarm summons trained help. Confine slows the fire by closing doors and windows. Extinguish is attempted last and only if it's safe. This order exists because a sedated or restrained patient cannot self-evacuate. Outside a hospital, you'd call for help first. But inside, the patient can't wait. So rescue always comes before the alarm. Picture the scene. Smoke fills a patient's room with a small fire in the wastebasket. The nurse rolls the bed into the hallway and shuts the door, then pulls the alarm. Other staff can find nearby doors, and only then does someone with an extinguisher approach the small, contained flame. RACE governs the whole response, while pass, pull, aim, squeeze, sweep only guides the extinguisher technique inside that final step. Keep the order straight. Rescue always comes first. Question 8. A nurse considers a patient becoming unstable with rising heart rate and falling blood pressure. The nurse considers how delegation changes when the patient's condition shifts. Tasks appropriate during stability may not fit during instability, since judgment and timely escalation are critical during a deteriorating situation. Your options are A. Continue all delegations as previously planned. B. Delegate even more tasks for efficiency. C. Reassume direct nursing responsibility for the patient. D. Avoid checking on the patient further. Got a guess? Lock it in. The correct answer is C. Reassume direct nursing responsibility for the patient. C is correct because when a patient becomes unstable, the registered nurse reassumes direct responsibility and may pull back tasks previously delegated. The nurse remains at the bedside, performs direct assessment, and coordinates the team for rapid evaluation and intervention. A is wrong because continuing all delegations as previously planned ignores the change in patient status. The new situation calls for closer registered nurse involvement, and tasks that fit before may not fit during the unstable period. B is wrong because delegating even more tasks for efficiency is unsafe in a deteriorating patient. The nurse must increase, not decrease, direct involvement, and pulling tasks back lets the nurse focus on the patient's care. D is wrong because avoiding the patient further is unethical and unsafe. The nurse should be at the bedside, performing direct assessment, communicating with the team, and ensuring rapid response to the developing clinical change at the moment. Delegation means transferring a task to another team member while the nurse keeps accountability for the outcome. A framework called the 5 rights guides every delegation decision, and one of those rights changes fastest when a patient becomes unstable. Before assigning anything, the nurse checks the task, the circumstance, the person, the direction, and the supervision plan. The right task is routine and predictable. The right circumstance is a stable patient. The right person has proper training. The right direction gives clear instructions. And the right supervision means the nurse follows up and reassesses. Picture a post-operative patient who was stable all afternoon until the heart rate climbs and blood pressure starts to drop. The assistant who was checking routine vitals reports the change, and the nurse takes over assessment directly, calls the rapid response team, and stays at the bedside. Delegation is sometimes confused with assignment or abandonment. Assignment is simply handing out patient loads, and abandonment means leaving a patient without proper coverage. Pulling back delegated tasks when a patient destabilizes is neither one. It's the right circumstance changing under the nurse's feet. Watch for STEM words like unstable, deteriorating, or changing condition. They're signaling that delegation must shrink, not grow, because clinical judgment now belongs at the bedside. Question 9. A nurse is teaching a patient newly discharged on home oxygen therapy about safety in the household. The patient cooks daily, has a gas stove, and lives with 2 adult relatives who smoke. The nurse provides specific guidance to reduce the risk of fire and serious injury while using oxygen. Your options are A. Keep oxygen tubing near the gas burner. B. Smoke in the same room briefly only. C. Store extra tanks in direct sunlight always. D. Avoid open flames and smoking near oxygen. Which one is it? Pause the video if you need more time. The correct answer is D. Avoid open flames and smoking near oxygen. D is correct because oxygen supports combustion, so any open flame or burning cigarette creates a serious fire risk. Patients must keep oxygen far from gas burners, lighters, candles, and smokers, and post no smoking signs in the home. A is wrong because keeping oxygen tubing near a gas burner places a flammable concentration of oxygen against an ignition source. The combination has caused severe burns and house fires in patients on home oxygen therapy. B is wrong because smoking briefly in the same room is still dangerous, because oxygen lingers in clothing and surfaces. Even without an active flame in hand, residual heat and embers can ignite the oxygen-rich environment. C is wrong because direct sunlight raises tank temperature and pressure, increasing the risk of failure or rupture. Tanks should be stored upright, in cool, well-ventilated spaces away from heat sources, sunlight, and ignition. Home oxygen therapy keeps patients breathing comfortably, but it also turns an ordinary living room into a place where fire behaves differently than anywhere else. The core science is simple. Oxygen supports combustion. Materials that smolder slowly in normal room air, like hair, clothing, bedding, and furniture, ignite rapidly once oxygen concentration rises. So a tiny spark becomes a large fire almost instantly. Because of that chemistry, patients and families learn a small set of rules. Keep open flame and cigarettes at least 6 feet from the equipment. Never smoke in the home. Avoid petroleum-based products on the face, and keep tanks upright and cool. Ventilated spaces away from sunlight and gas burners. Picture the danger zone extending several feet around the cannula and tank. Ignition sources like cigarettes, candles, and gas burners must stay outside that radius. And residual oxygen can linger in tubing and clothing even after the flow is switched off. The exam trap is the choice that seems harmless: a quick smoke in the next room, a cannula draped near the stove, a tank left in the sun. In an oxygen-rich household, there are no small exceptions. Question 10. A nurse is hanging a unit of packed red blood cells. The nurse considers the maximum recommended infusion time per unit to limit bacterial contamination risk. Each unit should hang within the institution's policy, and most facilities follow national guidelines that align with broader blood bank standards used widely. Your options are A. Up to 12 hours per unit safely. B. No epi-time limit applies. C. Up to 4 hours per unit. D. Up to 24 hours per unit. Take a second. Which answer would you pick? The correct answer is C. Up to 4 hours per unit. C is correct because each unit of packed red blood cells should infuse within 4 hours of leaving controlled storage. The limit reduces bacterial growth risk in a warm hanging unit and is enforced by institutional and national standards. A is wrong because 12 hours exceeds the safe window and risks bacterial contamination. The unit warms during hanging, and prolonged time outside cold storage allows organisms to grow rapidly within the infusion bag. B is wrong because there is a clear upper time limit on transfusion to ensure safety. Treating the time as unlimited risks bacterial overgrowth and is contrary to institutional and national blood transfusion guidelines used today. D is wrong because 24 hours per unit far exceeds safe limits and creates major contamination risk. The 4-hour rule is enforced precisely to prevent the dangers that would arise during prolonged hanging at room temperature. Once a unit of blood leaves cold storage, a strict clock starts ticking. Understanding why this rule exists helps explain why it never bends, no matter the situation. Cold storage keeps any stray bacteria dormant, but the moment the unit warms up, it becomes a culture medium. Even a tiny number of organisms can multiply into a dangerous, potentially fatal load within just a few hours. Mechanically, the nurse verifies patient identity and unit details with a second person at the bedside, starts the infusion slowly while staying present for the first 15 minutes, and records vital signs at baseline, at 15 minutes, periodically after, and at completion. When a fragile patient can only tolerate a slow infusion rate, the nurse never extends the unit past 4 hours. Instead, the blood bank splits the unit into smaller aliquots, so each portion can safely finish within its own 4-hour window. The 4-hour ceiling applies broadly across transfusion because it's rooted in bacterial growth physics, not patient tolerance. If the patient can't finish in time, split the unit, never stretch the clock. Question 11. A nurse is preparing a non-rebreather mask for a patient with severe hypoxia and distress. The nurse considers the proper setup for safe use of the device. The patient is alert but breathing rapidly. The flow setting and reservoir status both matter for effective oxygen delivery to this patient. Your options are A. Set flow to keep reservoir bag inflated. B. Allow reservoir bag to fully collapse. C. Run at 1 liter per minute only. D. Open all side ports for room air. Before I reveal it, which one do you think is right? The correct answer is A. Set flow to keep reservoir bag inflated. A is correct because flow must be high enough to keep the reservoir bag inflated through inhalation. A bag that empties means the patient is rebreathing exhaled air, which defeats the purpose of the high concentration mask. B is wrong because allowing the bag to fully collapse means the patient inhales mostly exhaled gas instead of fresh oxygen. The setup defeats the high concentration design and can lead to worsening hypoxia and carbon dioxide retention. C is wrong because 1 liter per minute is far below the flow needed to keep the reservoir inflated. The mask requires a flow that fills and maintains the bag throughout the breathing cycle of the patient. D is wrong because opening all side ports lets room air dilute the oxygen and breaks the seal that traps high concentrations. The mask design depends on closed side ports during inhalation to deliver near pure oxygen to the patient. Let's look closer at why the non-rebreather mask is built the way it is, and how its parts work together to deliver near pure oxygen. The device exists because severe hypoxia demands more oxygen than a cannula or basic mask can supply. Simple masks plateau around 50%, but a properly set up non-rebreather can approach 90%, bridging the gap before more advanced airway support is needed. Mechanically, the mask has 3 critical parts: the reservoir bag, which stores oxygen between breaths; the one-way valve, which stops exhaled gas from contaminating that reservoir; and the exhalation ports, whose flaps let air out but keep room air from leaking in. The exam trap is a setup that lets the bag collapse or the side ports stay open, since both let the patient rebreathe carbon dioxide or dilute the oxygen with room air. Flow must stay at 10 to 15 liters per minute, not 1, to keep the reservoir properly inflated. Picture a hypoxic patient placed on a non-rebreather at 15 liters per minute. The bag stays plump through inspiration, and saturation climbs into the 90s within minutes, confirming the device is delivering as designed. Question 12. A nurse calculates a Braden score of 12 for a patient. The nurse considers what the score signifies and what level of intervention to plan. Braden subscale scores examine sensory perception, moisture, activity, mobility, nutrition, and friction. Lower total scores indicate higher risk for pressure injury during the inpatient stay. Your options are A. Patient at no risk needing no interventions. B. Patient at low risk, routine measures only. C. Patient at very low risk overall. D. Patient at high risk needing aggressive prevention. What's your answer? Commit to one before I continue. The correct answer is D. Patient at high risk needing aggressive prevention. D is correct because a Braden score of 12 places the patient at high risk for pressure injury and triggers aggressive prevention. The nurse layers turning, surface, nutrition, moisture, and friction measures throughout the day on the unit. A is wrong because no risk corresponds to high scores, not 12. The score described falls in the high risk band, and treating the patient as no risk would skip the layered prevention measures that are clinically required here. B is wrong because low risk corresponds to higher Braden scores, typically near 15 to 18. A score of 12 falls below that band. So routine measures alone are insufficient, and additional interventions must be added to the plan. C is wrong because very low risk corresponds to the highest Braden scores, around 18 or above. 12 sits well below that range, marking the patient as high risk and not very low risk for pressure injury formation. The Braden scale is a structured tool nurses use to estimate a patient's risk of developing a pressure injury, and understanding how it works means understanding both its 6 subscales and its inverted scoring logic. The scale scores 6 subscales: sensory perception, moisture, activity, mobility, nutrition, and friction and shear. Each earns points based on observation, and the points are summed into a single total. The relationship is inverted. A lower total score means higher risk, not lower risk. This is the exact trap exam writers exploit, pairing a high-risk numeric score with answer choices that casually describe low or minimal risk. The cutoffs run from 19 to 23 for no risk, down through mild, moderate, high, and very high risk at 9 or below. A score of 12, for example, sits squarely in the high-risk band and demands aggressive prevention. Whenever a STEM gives you a Braden total, resist the instinct to read a low number as low risk. Lower always means higher risk, and that single principle drives the entire prevention plan. Question 13. A nurse is reviewing oxygen therapy equipment and considers when supplemental humidification is most important. The patient is on continuous nasal cannula oxygen at 6 liters per minute. The nurse considers the rationale for adding humidification at higher flow rates rather than relying on dry oxygen for prolonged therapy. Your options are: A. Humidification reduces oxygen concentration. B. Dry oxygen prevents nosebleeds always. C. Humidification reduces drying of mucous membranes. D. Humidification raises infection risk every time. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Humidification reduces drying of mucous membranes. C is correct because humidification reduces drying of nasal and pharyngeal mucous membranes during higher flow oxygen. The added moisture protects tissue, prevents bleeding, and improves comfort during prolonged therapy at flow rates above 4 liters per minute. A is wrong because humidification does not reduce oxygen concentration in any meaningful way. The added water vapor sits in the gas mixture without displacing the oxygen that the patient receives at the prescribed flow rate. B is wrong because dry oxygen actually causes nosebleeds rather than preventing them, especially at higher flow rates. The mucous membranes dry, crack, and bleed when high flow gas is delivered without adequate humidification over time. D is wrong because humidification systems can introduce infection if not maintained properly, but with proper care infection risk is low. The benefit of preventing dryness usually outweighs the manageable risk in most clinical scenarios. Compressed oxygen arrives bone dry, and at higher flow rates the nose and airway can't add enough moisture on their own. Humidification devices solve this by saturating the gas with water vapor before it reaches the patient. Dry gas damages mucous membranes, causing irritation, nosebleeds, and crusting, while impairing the cilia that normally clear the airway. Patients become reluctant to keep the cannula on, which undercuts the whole therapy. Mechanically, the humidifier sits between the flow meter and the cannula tubing. Oxygen bubbles up through sterile water, picking up moisture along the way, and a heated version can add even more vapor for high flow or non-invasive support. Test writers like to claim humidification dilutes the oxygen concentration or always raises infection risk. Sahel said, neither is true with sterile water and routine changes. Others claim it's never necessary, ignoring the real comfort and tissue protection benefit. Remember, humidification protects the airway during oxygen delivery, while nebulization actually treats the lungs with medication. Keep that distinction clear and the traps fall away. Question 14. A nurse is preparing to administer a cardiac medication that requires checking the apical pulse before each dose. The nurse considers the location and method for an accurate apical reading. The patient is sitting upright in the chair and tolerating the assessment without difficulty during the morning round. Your options are: A. Stethoscope at 5th intercostal space mid-clavicular. B. Palpation at the radial pulse site. C. Palpate carotid pulse for full minute. D. auscultate at right second intercostal space. Which would you go with? Lock it in before the reveal. The correct answer is A. Stethoscope at fifth intercostal space mid-clavicular. A is correct because the apical pulse is auscultated at the fifth intercostal space at the mid-clavicular line, where the apex of the heart lies. The nurse listens for 1 full minute to confirm rate, rhythm, and any irregularity. B is wrong because radial palpation is not the apical pulse and may miss irregular beats from atrial fibrillation. Apical auscultation is required for medications like digoxin to count beats accurately at the heart. C is wrong because carotid palpation is used in emergencies and not for routine apical pulse counting before medications. The carotid site can also stimulate the vagus nerve and slow the rate during palpation. D is wrong because the right second intercostal space is the aortic auscultation area and not the apex location. The apex is on the left side of the chest at the fifth intercostal space at mid-clavicular line. The apical pulse is the heart rate heard directly over the apex of the heart, and it's the gold standard before giving cardiac medications like digoxin. The apex of the heart sits at the left fifth intercostal space at the midclavicular line, slightly inside the nipple line, and this is exactly where the stethoscope goes. This technique exists because peripheral pulses can deceive. In conditions like atrial fibrillation or low cardiac output, some beats are too weak to reach the radial artery, so counting at the wrist understates the true heart rate. The nurse places the diaphragm at the fifth intercostal space, mid-clavicular line, and listens for the S1 lub sound. Every lub is counted for a full 60 seconds while noting rhythm regularity and any extra sounds. Exam traps often swap in the wrong site. The aortic area at the right second intercostal space assesses valves, not rate. The radial pulse skips medication checks and the carotid risk vagal stimulation. The apical radial pulse is a different technique entirely, needing 2 clinicians to detect a pulse deficit. Question 15. A nurse caring for a patient with an indwelling urinary catheter considers the most important measure to prevent catheter-associated urinary tract infection during the stay. The catheter has been in place for 2 days and the patient is alert and tolerating it. The nurse selects an evidence-based action. Your options are A. Disconnect the system every shift to flush. B. Hang collection bag above bladder level. C. Routinely change tubing each 12 hours. D. Keep bag below bladder, ensure closed system. Don't overthink it. Which one feels right? The correct answer is D. Keep bag below bladder, ensure closed system. D is correct because keeping the drainage bag below the level of the bladder uses gravity to prevent backflow into the bladder. Maintaining the closed system reduces the introduction of bacteria along the catheter pathway during care. A is wrong because disconnecting the closed system breaks sterile barriers and increases infection risk. The system should remain closed except for emptying through the spout, and routine disconnection has no benefit during routine care. B is wrong because hanging the bag above bladder level allows urine to flow back toward the bladder. Reflux of urine carries pathogens upward and increases the chance of catheter-associated urinary tract infection during the stay. C is wrong because routine tubing changes every 12 hours are unnecessary and disrupt the closed system. Tubing is changed only when contamination, leak, or specific clinical concern requires intervention rather than on a fixed short interval. A catheter creates a direct pathway from the outside world into the normally sterile bladder, letting bacteria travel along the inside or outside of the tube. That's why catheter-associated urinary tract infections are among the most common healthcare-associated infections, yet largely preventable with proper bundle adherence. Mechanically, The bag must always stay below bladder level, so gravity keeps urine flowing downward and prevents reflux of contaminated urine back into the bladder. Tubing is secured to the leg to avoid trauma, and the system is kept closed and undisturbed. The bundle works because each piece targets a different transmission risk: sterile insertion, an unbroken closed system, correct bag positioning, and a daily question of whether the catheter is still needed. Together, these elements sharply reduce cavity rights. Watch for options that break the closed system. Raise the bag above the bladder, or call for routine tubing changes. Each of these introduces bacteria or allows reflux, defeating a specific bundle element without any real benefit. Remember, a properly maintained closed system with the bag below the bladder, paired with a daily necessity check, is what prevents COTEs. Skipping even one element still leaves the patient at risk. Question 16. A nurse is caring for a post-operative patient who has not voided 8 hours after surgery and reports lower abdominal discomfort. The bladder is palpable above the symphysis pubis. The nurse considers the most appropriate next action while preparing to communicate findings to the provider for further direction today. Your options are: A. Bladder scan and then offer voiding measures. B. Insert indwelling catheter without further checks. C. Document and continue regular rounds quietly. D. Encourage 3 large glasses of fluid. Got a guess? Lock it in. The correct answer is A. Bladder scan and then offer voiding measures. A is correct because a bedside bladder scan quantifies retention non-invasively and informs the next step. The nurse can also offer non-invasive measures like running water, perineal warmth, and a private bathroom before any catheter is considered. B is wrong because inserting an indwelling catheter without first quantifying retention or trying non-invasive measures is premature. Catheterization carries infection risk and should be reserved for confirmed retention that does not resolve with simpler interventions first. C is wrong because documenting and continuing rounds ignores a patient with bladder distension and discomfort. The finding requires action, not passive monitoring, since prolonged retention can cause bladder injury and worsening pain over the next hours. D is wrong because encouraging 3 large glasses of fluid worsens bladder distension without addressing the retention. Fluid intake will not help when the patient cannot empty the bladder. The priority is to assess the volume present. Post-operative urinary retention is the inability to empty the bladder after surgery, despite feeling the urge to void. It's common because anesthesia, opioids, immobility, and altered fluid balance all interfere with normal bladder function, and left untreated, it can stretch the bladder and invite infection. The standard workflow exists because catheterization is invasive and risky, while non-invasive measures often work if given a chance. National efforts to reduce catheter-associated infections push nurses to assess carefully first, and bedside bladder scanners made that assessment fast and non-invasive. Mechanically, the assessment combines history, palpation, and a bladder scan. The nurse checks time since last void and sensation of fullness. Palpation may reveal a distended bladder above the symphysis pubis, and the scan gives an objective volume in milliliters. Exam traps include jumping straight to catheterization without measuring retention, pushing more fluids which worsens distension, or simply documenting without acting. The correct sequence is always scan, try non-invasive measures, then escalate only if needed. Retention means the bladder is producing urine normally but can't empty it, unlike anuria or renal failure, which are kidney problems with no distended bladder. Recognizing that distinction keeps the response focused. Scan first. Try non-invasive measures, and escalate only when truly necessary. Question 17. A nurse caring for a patient with a chest tube notices The water-sealed chamber has continuous bubbling. The drainage is small and the patient is alert. The nurse considers what the bubbling pattern indicates. Different bubbling patterns signal normal water seal function or air leak in the system. Your options are A. Normal expected pattern at all times. B. Patient is fully healed and ready. C. System is clamped and not draining. D. Air leak somewhere in the system. Which one is it? Pause the video if you need more time. The correct answer is D. Air leak somewhere in the system. D is correct because continuous bubbling in the water-sealed chamber suggests an air leak somewhere in the system. The nurse traces the tubing for connection issues and notifies the provider, since the leak source must be identified and corrected. A is wrong because continuous bubbling is not the normal pattern. Intermittent bubbling with respirations may be expected during initial drainage. The persistent pattern points to an abnormal air leak that warrants investigation, not reassurance about normal function. B is wrong because continuous bubbling does not indicate full healing or readiness for chest tube removal. Healing is suggested by absence of bubbling, decreased drainage, and clinical stability over time, not by an active leak in the system. C is wrong because a clamped or non-draining system would not show continuous bubbling. The bubbling actually requires air movement through the chamber, which means the system is functioning rather than being completely blocked off. Let's look at why the water-sealed chamber is the key to understanding a chest tube drainage system. A standard chest tube system has 3 chambers: a collection chamber that gathers fluid, a water-sealed chamber that prevents air from re-entering the chest, and a suction control chamber that regulates negative pressure. Of these, the water-seal tells the nurse the most about what's happening inside the chest. The pleural space is normally sealed and low pressure, allowing the lungs to expand. When air enters through injury, the chest tube evacuates it, and the water seal lets air bubble out but blocks it from ever flowing back in. Titling, the gentle rise and fall of fluid with breathing means the system is patent. Intermittent bubbling early on can reflect normal air evacuation, but continuous bubbling signals an air leak, while healing shows up as decreasing bubbling and drainage over time, never persistent bubbling. When you see continuous bubbling, don't call it normal, healing, or a sign the system is clamped. A clamped system wouldn't bubble at all. Instead, trace the tubing from patient to drainage unit to find and fix the leak. Question 18. A nurse preparing a new medication notes the patient's chart documents a possible allergy to a related drug. The nurse considers the appropriate action before administration. Allergy verification is part of safe practice, and the nurse must confirm details before exposing the patient to risk. Your options are A. Skip the medication without checking. B. Give the dose anyway and watch closely. C. Verify with patient and contact provider. D. Contact the pharmacy to remove the alert. Take a second. Which answer would you pick? The correct answer is C. Verify with patient and contact provider. C is correct because the nurse verifies the allergy with the patient, including the reaction type, and then contacts the provider to discuss whether the medication is safe. The clarification protects the patient and updates the chart for future reference. A is wrong because skipping the medication without checking could leave a needed dose unadministered. The patient may have only had a mild rash, and the medication may still be safe. So verification is preferred over abandonment. B is wrong because giving the dose anyway without verification ignores a serious safety alert. The patient could have anaphylaxis to the medication, and the nurse must clarify rather than proceeding into a possible adverse event. D is wrong because contacting pharmacy to remove the alert is inappropriate without first verifying the allergy. The alert protects the patient, and removing it without clarification creates risk for future medication encounters at the institution. Before giving any medication, a nurse must verify what a documented allergy actually means, because a chart entry never tells the whole story. Verification means gathering specifics, the drug involved, the exact reaction, when it happened relative to the dose, how severe it was, and whether treatment was needed. Hives, swelling, and breathing changes point to a true allergy, while nausea alone often points to a mere side effect. Picture a patient with a charted penicillin allergy who needs a cephalosporin. The nurse asks about the reaction, learns it was only a mild rash decades ago, and relays this to the provider, who approves the medication under observation while the chart gets updated. Exam traps include giving the drug anyway, withholding it without check-in, or asking pharmacy to remove the alert, since pharmacy doesn't hold the reaction history. The real answer always involves the patient and provider together, and this differs from adverse event reporting or medication reconciliation, which happen at other points in care. Allergy verification is the bedside step that protects the patient before a single dose is given. Question 19. A nurse considers the elements of nursing negligence. 4 elements must be present for negligence to be established legally. The nurse identifies the elements of negligence. Recognizing the elements helps the nurse practice safely and document carefully, since each element must be proven in any legal claim against a nurse. Your options are A. Intent, planning, action, regret. B. Duty, breach, causation, damages. C. Order, judgment, action, outcome. D. Patient, nurse, family, court. Before I reveal it, which one do you think is right? The correct answer is B. Duty, breach, causation, damages. B is correct because negligence requires duty, breach of that duty, causation linking the breach to harm, and actual damages. All 4 must be proven for legal negligence, which is why careful nursing practice and documentation help protect against liability claims. A is wrong because intent, planning, action, and regret are not the legal elements of negligence. Negligence does not require intent, it requires breach of duty causing harm, and the legal framework names specific elements that must be present. C is wrong because order, judgment, action, and outcome do not match the legal elements of negligence. The legal framework specifies duty, breach, causation, and damages as the 4 required elements that must be proven in court. D is wrong because patient, nurse, family, and court are participants in a case, not elements of negligence. The legal definition specifies the 4 conditions that must be present for negligence to be established as a legal claim. Negligence exists so society can hold professionals accountable for harm while still letting medicine and nursing move forward. 4 elements must be proven together for a claim to succeed. Duty arises when a nurse accepts responsibility for a patient. Breach is failing the standard a reasonable nurse would meet. Causation ties that failure directly to the harm. Damages are the real injury that resulted. Picture a nurse assigned to a post-operative patient establishing duty. Hourly checks were skipped, creating a documented breach, which caused an undetected hemorrhage and led to real damages, emergency surgery, and a longer stay. Don't confuse negligence with its relatives. Malpractice is just negligence applied to licensed professionals. Intentional torts, like assault or battery, require intent, which negligence never does. Criminal acts violate public law and carry different consequences entirely. Watch for exam traps listing intent, planning, or court participants instead of the real elements. Negligence needs no intent, only failure of reasonable care, proven through duty, breach, causation, and damages. Question 20. A nurse is reviewing PPE for several patients on the unit. One patient has measles, another has influenza, and another has pertussis. The nurse considers which patient requires an N95 respirator rather than a surgical mask, since the type of precaution depends on the route of transmission for the organism. Your options are A. Measles patient on airborne precautions, B. Influenza patient on droplet precautions, C. Pertussis patient on droplet precautions, D. All three need N95 respirator use. What's your answer? Commit to one before I continue. The correct answer is A. Measles patient on airborne precautions. A is correct because measles travels by airborne route on small particles that linger in the air. Airborne precautions require an N95 or higher respirator, a private room with negative pressure, and limited unmasked entry into the room. B is wrong because influenza spreads by droplet, which falls quickly within about 3 feet of the source. Droplet precautions use a surgical mask, gloves, and gown when within close range of the patient during care. C is wrong because pertussis is transmitted by droplet, not airborne particles. A surgical mask is appropriate for droplet precautions, and an N95 is not required for routine pertussis care under most policies and guidelines. D is wrong because not all three need N95, only the airborne organism does. Using N95 unnecessarily wastes resources and is not required when droplet protection alone is adequate for the route of transmission involved. Transmission-based precautions add extra protection on top of standard precautions for patients with known or suspected infections, and the category a nurse chooses must match how the organism actually spreads. Airborne organisms ride tiny particles that linger and travel far. Droplet organisms travel on larger particles that fall within a few feet, and contact organisms spread through direct or indirect touch. Airborne precautions require a fitted N95 respirator, a private negative pressure room, and a closed door. Droplet precautions require a surgical mask within several feet, along with gloves and a gown if contact is likely. Contact precautions require gloves, gown, dedicated equipment, and careful hand hygiene. Measles, tuberculosis, and varicella are airborne and demand a fitted respirator, while influenza, pertussis, and meningococcal disease are droplet and only require a surgical mask. The exam trap is swapping these, putting a flimsy mask on an airborne pathogen or wasting a respirator on a droplet one. Standard precautions protect against every patient, but transmission-based precautions are the extra layer built for a specific organism, so the nurse must always choose the precise category and gear rather than treat in isolation as one generic idea. Question 21. A nurse is writing care plan goals for a frail 88-year-old patient recovering from a hip repair. The nurse must choose an outcome that is realistic, patient-centered, and individualized to the patient's baseline and tolerance level rather than a copy from a textbook for younger adults. Your options are A. Patient runs a mile day 3. B. Nurse will encourage ambulation each shift. C. Patient will return to baseline strength. D. Patient walks to chair with assistance today. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Patient walks to chair with assistance today. D is correct because walking to the chair with assistance suits the patient's frailty and recent surgery while still pushing a measurable, time-bound action. The outcome is realistic, individualized, and tied to clear bedside observation today. A is wrong because running a mile by day 3 is unrealistic for any post-hip repair patient and especially unsafe for a frail older adult. The outcome ignores the actual recovery trajectory and protective weight-bearing limits. B is wrong because nurse will encourage ambulation describes an intervention, not an outcome. SMART outcomes are written from the patient's viewpoint and describe what the patient will accomplish, feel, or demonstrate during the shift. C is wrong because return to baseline strength is too vague and lacks a measurable time anchor or observable behavior. Without numbers or an evaluation point, the nurse cannot decide whether the goal has been met today. A SMART outcome is a nursing goal that is specific, measurable, achievable, relevant, and time-bound. It describes what the patient will do or demonstrate, written from the patient's point of view, not the nurse's. Specificity tells the nurse exactly what to look for. Measurability adds numbers or observable behaviors. Achievability matches the patient's current baseline. Relevance ties the goal to the priority problem. And time anchors it to a moment for evaluation. These are often confused with each other. The diagnosis names the problem. The outcome names the desired patient result. And the intervention names what the nurse actually does. 3 different jobs in one care plan. Picture an 88-year-old one day after hip repair. The nurse writes the outcome, walks to the bedside chair with one-person assistance during the day shift, then supports it with interventions like pre-medication, non-skid socks, and a gait belt, and evaluates at end of shift. A well-written outcome gives the whole care team a clear, realistic target to aim for and a specific moment to evaluate it. Question 22. A nurse during a true fire on the unit must decide which patient to evacuate first when help is limited. The nurse remembers the order based on patient ability to move and proximity to danger. Several patients have differing levels of mobility and current locations during the fire response. Your options are: A. Begin with the most distant patient. B. Evacuate sleeping patients only at end. C. Move ambulatory patients nearest fire first. D. Take comatose patient immediately first. Which would you go with? Lock it in before the reveal. The correct answer is C. Move ambulatory patients nearest fire first. C is correct because ambulatory patients close to the fire move quickly with minimal help and clear the corridor for others. After ambulatory rescue, the nurse moves wheelchair patients and finally bedbound patients with greater equipment and personnel needs. A is wrong because starting with the most distant patient delays rescue of those nearest to the active danger. The closest at-risk patients face the most heat and smoke and must be moved out of the immediate fire zone first. B is wrong because evacuating sleeping patients at the very end ignores their actual location and ability. A sleeping patient near the fire must be rescued early. The nurse evacuates by location and mobility, not sleep state alone. D is wrong because taking the comatose patient first uses up early staff time on the slowest, heaviest move. Ambulatory patients can self-rescue with minimal direction. Bedbound and unconscious patients are evacuated last when more help has arrived. When fire breaks out on a hospital floor, evacuation order isn't about compassion first. It's about resource allocation under extreme time pressure. The standard order moves ambulatory patients first, then wheelchair patients, then bedbound or unconscious patients. Fast movers clear themselves with minimal help, freeing staff and time for those who truly need it. Picture the corridor, fire at one end, a safe exit at the other. Nurses send walking patients out first, wheelchair patients next with an escort, and bedbound patients last, moved by bed or transfer equipment with multiple staff. The exam trap is starting with the most dependent patient out of compassion, which ties up the most staff, while an ambulatory patient nearby could have walked out alone. Another trap is evacuating from far to near, when the closest patients actually face the worst heat and smoke. This differs from triage or the START method, which prioritizes treatment by severity. In a fire, the threat moves toward the patient, so evacuation logic is built around speed and proximity to danger, not how sick someone is. Question 23. A nurse teaches a postoperative patient to recognize signs of deep vein thrombosis at home. The patient is going home on the day of teaching. The nurse considers the cluster of findings that should prompt the patient to seek care, since untreated clots can progress to pulmonary embolism rapidly. Your options are A. Sudden cough swelling, warmth, redness, pain. B. Mild ankle stiffness in the morning. C. Rare brief twinges in the foot. D. Slight skin dryness on the calves. Don't overthink it. Which one feels right? The correct answer is A. Sudden calf swelling, warmth, redness, pain. A is correct because sudden calf swelling, warmth, redness, and pain suggest deep vein thrombosis. The patient should seek care promptly, since untreated clots can break free and travel to the lungs as a pulmonary embolism with serious consequences. B is wrong because mild ankle stiffness in the morning is common after surgery and does not signal deep vein thrombosis. The finding is unrelated to clot formation and resolves as the patient moves through the day. C is wrong because rare brief twinges in the foot are not specific for deep vein thrombosis. The findings worth reporting are more sustained calf swelling, warmth, redness, and pain rather than brief sensations during normal recovery. D is wrong because slight skin dryness on the calves is unrelated to deep vein thrombosis. The Q list focuses on swelling, warmth, redness, and pain, which reflect inflammation and clot formation rather than skin texture changes. Let's look at why deep vein thrombosis happens after surgery and how to recognize it before it turns fatal. Clots form through three mechanisms known as Virchow's triad: stasis, endothelial injury, and hypercoagulability. Surgery triggers all three at once. Immobility causes stasis. Surgical trauma and IV lines cause endothelial injury, and the inflammatory response plus dehydration cause hypercoagulability. The clot lodges in a deep vein, often in the calf or thigh, blocking normal blood flow. This produces the classic signature: sudden, focal, unilateral swelling, warmth, redness, and pain in one leg. Exam questions try to confuse DVT with cellulitis, muscle strain, or chronic venous insufficiency. Cellulitis brings systemic illness, strain has a clear injury history, and venous insufficiency causes gradual bilateral swelling. DVT stands apart because it's sudden, focal, and one-sided. Once a clot embolizes to the lungs, the window to act closes fast. Teach patients to recognize sudden, one-sided cough changes early, so they call, get scanned, and start treatment before it's too late. Question 24. A nurse encounters a serious, unexpected adverse event causing significant harm. The institution requires immediate response and a structured analysis. The nurse considers the term used for this event and the typical follow-up. The classification triggers a process designed to prevent recurrence. Your options are A. Routine event with no follow-up needed. B. Minor variation managed by single nurse. C. Near-miss event with no patient impact. D. Sentinel event triggering root cause analysis. Got a guess? Lock it in. The correct answer is D. Sentinel event triggering root cause analysis. D is correct because sentinel events are unexpected occurrences involving death, serious physical or psychological injury, or risk thereof. Institutions perform root cause analysis to identify contributing factors and implement corrective actions that prevent similar events in the future across the system. A is wrong because routine events with no follow-up do not match the description of an event causing significant harm. The classification does not apply to events without serious adverse outcomes, since sentinel events specifically require harm or imminent risk. B is wrong because minor variation managed by a single nurse does not meet the sentinel event threshold. The label requires significant harm, which exceeds what a single nurse manages alone during routine variation in clinical practice today. C is wrong because near-miss events with no patient impact are reported and analyzed, but do not meet the sentinel event definition. The distinction matters because sentinel events trigger more intensive review and reporting under regulatory standards. A sentinel event is an unexpected occurrence involving death, serious physical or psychological injury, or the risk of either. The Joint Commission tracks these events because they demand immediate investigation and response. Not every adverse event requires the same response. Minor variations get routine review. Near misses prompt analysis since harm was avoided, and sentinel events sit at the top, requiring rapid action and a full root cause analysis. Root cause analysis gathers a multidisciplinary team to reconstruct the timeline, interview staff, and examine records. The goal is to find system failures, not individual blame, and to produce recommendations with assigned owners, deadlines, and a follow-up review. The classic trap is an option that minimizes a serious harm event or mislabels it as routine. Another trap calls a near miss a sentinel event, but near misses avoid harm entirely and don't meet the sentinel definition, even though many institutions still analyze them. The defining feature of a sentinel event is unexpected serious harm or imminent risk of it, which triggers a formal root cause analysis under accreditation standards. Everything else is reviewed, but only this triggers the full response. Question 25. A nurse is preparing a Venturi mask for a patient with chronic obstructive pulmonary disease. The nurse considers the device's main advantage compared to other oxygen masks. The patient needs a precise oxygen concentration to avoid suppressing the hypoxic respiratory drive while still treating the underlying hypoxemia present today. Your options are A. Highest possible concentration of oxygen. B. Precise fixed oxygen concentration delivery. C. Delivers humidified oxygen at any flow. D. Eliminates need for monitoring saturation. Which one is it? Pause the video if you need more time. The correct answer is B. Precise fixed oxygen concentration delivery. B is correct because the Venturi mask uses interchangeable adapters to deliver a precise fixed oxygen concentration. The control matters in chronic obstructive pulmonary disease, where excessive oxygen can blunt the hypoxic drive and worsen carbon dioxide retention. A is wrong because the Venturi mask does not deliver the highest concentration. Non-Rebreather masks reach higher levels. The Venturi system trades concentration for precision, which is exactly what is needed for the chronic obstructive disease patient. C is wrong because humidification is not the defining feature of a Venturi mask, and humidification can be added to many oxygen systems. The precise concentration delivery is the unique advantage that distinguishes Venturi from other masks. D is wrong because oxygen saturation monitoring is still required regardless of which delivery device is used. No oxygen device removes the need for monitoring, since titration depends on the patient's response to therapy in real time. The Venturi mask delivers a precise, predictable concentration of oxygen, not just a high one. That precision, not raw power, is the whole point of the device. Oxygen jets through a narrow opening in the adapter, and that speed creates a pressure drop, the Bernoulli effect. This pressure drop pulls a fixed amount of room air through entrainment ports, and the adapter's opening size sets the exact oxygen to air ratio. In chronic carbon dioxide retention, the body's chemoreceptors shift from using carbon dioxide to using oxygen as the trigger to breathe. Give too much oxygen, and you blunt that drive. Carbon dioxide climbs further, and the patient can slide into respiratory failure. The simple face mask gives a variable concentration depending on flow and breathing pattern. The Non-Rebreather delivers the highest concentration using a reservoir bag. The Venturi sits in the middle, trading peak concentration for exact precision. and humidification is not its defining feature since it can be added to many devices. The exam trap is calling the Venturi the highest concentration device, but that title belongs to the Non-Rebreather. The Venturi's job is precision, exactly what a hypoxic drive patient needs. Question 26. A nurse working with parenteral medications is using needles and syringes throughout the shift. The unit has labeled sharps containers in every patient room. The nurse considers the safest practice for handling needles after injections to reduce the risk of needle stick injury and exposure to bloodborne pathogens. Your options are A. Recap needles to make safer for transport. B. Place used needles on counter briefly. C. Activate safety device drop-in container. D. Pass uncapped needle to colleague to discard. Take a second. Which answer would you pick? The correct answer is C. Activate safety device drop-in container. C is correct because activating the engineered safety device and dropping the needle directly into the puncture-resistant container is the standard practice. The nurse never recaps and never passes uncapped needles between hands or between staff members. A is wrong because recapping needles is a leading cause of needle stick injuries because the nurse may miss the cap. Engineered safety devices on modern needles eliminate the need to recap and protect the user during disposal. B is wrong because placing used needles on a counter creates a hazard for the next person who walks by. Sharps must go directly into the puncture-resistant container at the point of use, not on shared surfaces. D is wrong because passing uncapped needles between staff increases the chance of injury during the handoff. The user who created the sharp must dispose of it personally rather than transferring the hazard to a coworker. Sharps safety is the set of practices that prevent needle stick injuries and exposure to bloodborne pathogens like hepatitis B, hepatitis C, and HIV. The danger peaks not during use but during disposal, which is where most injuries actually happen. The workflow has a few simple rules. Use engineered safety devices whenever possible. Activate the safety mechanism before the needle leaves your hand, and drop it straight into a puncture-resistant container. Never recap, bend, pause, or set down an uncapped needle. Picture a nurse giving a subcutaneous heparin injection. Insert, inject, withdraw, then press the safety button before the hand even moves. The sheath needle drops straight into the sharps container at the bedside, so no bare needle ever touches a counter or another person. Don't confuse sharp safety with personal protective equipment. Sharps safety targets the moment of needle handling to prevent puncture injuries, while PPE covers gloves, gowns, masks, and eye protection to prevent fluid exposure to skin and mucous membranes. They work together but guard against different risks. The classic exam trap is recapping a needle for safe transport. Once standard practice, now the leading cause of needle stick injuries. Watch for options that recap, transfer, or stage uncapped needles, and choose the one that drops the activated needle straight into the sharps container. Question 27. A nurse administers a first dose of an antibiotic and the patient soon develops hives, lip swelling, throat tightness, and wheezing. The nurse considers the priority intervention while a colleague calls the rapid response team and prepares additional emergency medications for the systemic allergic reaction. Your options are A. Continue infusion and chart findings. B. Encourage extra oral fluids quickly. C. Apply cool compress to face. D. Stop infusion and prepare epinephrine. Before I reveal it, which one do you think is right? The correct answer is D. Stop infusion and prepare epinephrine. D is correct because anaphylaxis requires stopping the infusion immediately and preparing epinephrine as the first-line treatment. The nurse maintains airway, applies oxygen, supports circulation, and prepares additional medications and equipment as the team responds to the emergency. A is wrong because continuing the infusion delivers more of the offending drug. The action worsens the reaction by maintaining exposure to the trigger, exactly when removal of the trigger is the most important first step in management. B is wrong because encouraging fluids cannot reverse a systemic allergic reaction in progress. The patient has airway swelling and circulatory compromise. Oral hydration is unsafe and irrelevant during the acute event that is unfolding right now. C is wrong because a cool compress to the face does not address airway compromise or hypertension. Topical comfort measures have no role in treating systemic allergic reactions, which require immediate medication administration and supportive care quickly. Anaphylaxis is a severe whole-body allergic reaction that can strike within minutes of exposure to an allergen. Mast cells and basophils flood the body with histamine, causing vasodilation, capillary leakage, smooth muscle contraction, and airway compromise, leading to hives, swelling, wheezing, and dangerously low blood pressure. Epinephrine is first line because it does three things at once. It constricts blood vessels to raise blood pressure, relaxes airway smooth muscle to open the lungs, and reduces further mast cell mediator release. Antihistamines and corticosteroids only address the late phase reaction. They cannot reverse acute airway and circulatory collapse. Histamine release drives widespread vasodilation and capillary leak, smooth muscle contraction, and airway swelling all at once, which is why the presentation is so sudden and multi-system. The correct sequence is stop the exposure, prepare and give intramuscular epinephrine in the lateral thigh. Support the airway and circulation with oxygen and positioning. Then add adjunct medications and monitor for a late biphasic reaction. The exam trap is any option that continues the infusion or offers only comfort measures like cool compresses or oral fluids. Unlike a mild hives-only reaction or a vasovagal episode with pallor alone, anaphylaxis is fast, multi-system, and life-threatening, demanding the full sequence every time. Question 28. A nurse caring for a patient with a central venous catheter reviews the bundle of practices that prevent central line-associated bloodstream infection. The nurse considers the standard elements of the bundle. Each element addresses a specific risk during catheter insertion or maintenance during the patient's stay on the unit. Your options are: A. Avoid hand hygiene before catheter contact. B. Use chlorhexidine-based skin antisepsis. C. Replace dressings only at discharge. D. Manipulate ports without disinfection. What's your answer? Commit to one before I continue. The correct answer is B. Use chlorhexidine-based skin antisepsis. B is correct because chlorhexidine-based skin antisepsis is part of the central line bundle for insertion and care. The bundle also includes hand hygiene, maximal sterile barriers, dedicated insertion checklist, and daily review of necessity for the line. A is wrong because avoiding hand hygiene contradicts the bundle and raises infection risk. Hand hygiene before any catheter contact is one of the most important elements of central line care and is required every time. C is wrong because dressings are changed on a regular schedule and whenever they become damp or loose, not only at discharge. Routine dressing changes maintain a clean, intact, occlusive barrier over the insertion site for protection. D is wrong because manipulating ports without disinfection introduces pathogens directly into the bloodstream. The nurse scrubs the hub for the recommended duration with an alcohol or chlorhexidine product before each access of the line. Central line infections are deadly, costly, and preventable. That's why hospitals adopted the central line bundle, a set of evidence-based practices that, applied together, drive infection rates towards zero. A central line sits in a major vein for extended periods, so any break in technique can let pathogens into the bloodstream. These infections lengthen hospital stays, raise mortality, and add significant cost, which is why bundled practices outperform any single intervention. During insertion, clinicians use maximal sterile barrier precautions, cap, mask, sterile gown, sterile gloves, and a full body drape, combined with chlorhexidine antisepsis at the site, often favoring the subclavian vein over the femoral. The full bundle covers 6 elements: hand hygiene, maximal sterile barriers, chlorhexidine skin antisepsis, optimal site selection, daily review of line necessity, and scrubbing the hub before every access. Exam traps usually involve skipping one of these or claiming one element alone equals the whole bundle. The central line bundle is a specific, named set of practices for a high-risk device, distinct from general infection control or peripheral line care. It only works when every element is applied together. Question 29. A nurse cares for a patient one day after total hip arthroplasty using the posterior approach. The nurse considers movement precautions that prevent dislocation. The patient is alert and able to follow directions. Specific positions and movements increase posterior dislocation risk in the early post-operative period. Your options are: A. Cross legs and rotate operative leg inward. B. Bend the hip past 90 degrees often. C. Avoid crossing legs and use abductor pillow. D. Sit on low couch for comfort. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Avoid crossing legs and use abductor pillow. C is correct because avoiding leg crossing and using an abductor pillow keep the new hip in safe alignment. The patient also avoids hip flexion past 90 degrees, internal rotation, and adduction during the early healing period after the posterior approach. A is wrong because crossing legs and rotating the operative leg inward both place the prosthesis at high risk of dislocation. The patient must keep the legs apart and avoid internal rotation during the early post-operative recovery weeks. B is wrong because bending the hip past 90 degrees can dislocate the prosthesis after a posterior approach. The patient must avoid extreme hip flexion during sitting, transfers, and toileting throughout the early healing period. D is wrong because sitting on a low couch forces the hip into deep flexion, increasing dislocation risk. The patient should use a higher chair with arms to keep the hip below the recommended flexion limit during healing. After a posterior approach total hip arthroplasty, the posterior capsule is weakened until scar tissue forms, leaving the new hip vulnerable to dislocation during early recovery. Mechanically, the precautions come down to 3 core rules: no hip flexion past 90 degrees, no internal rotation of the operative leg past neutral, and no adduction past the midline. Crossing the legs combines internal rotation and adduction, making it especially dangerous. An abductor pillow between the legs maintains slight abduction and prevents the leg from drifting into adduction while the patient sleeps, protecting the healing posterior capsule. In practice, this means an abductor pillow in bed, a high chair with arms instead of low couches, a raised toilet seat, and a reacher or long-handled shoehorn for dressing without bending too far forward. Watch for exam traps that allow crossing legs or deep flexion, or that forbid all movement entirely. The goal is safe movement, not no movement. And always confirm posterior versus anterior approach since the precautions differ. Question 30. A nurse is planning care for a patient 3 days after a stroke who is having difficulty swallowing thin liquids and has a wet voice after sips of water. The plan must include an action that involves coordinating with another discipline to evaluate safe oral intake. Your options are: A. Consult speech-language pathologist for swallow study. B. Place nasogastric tube to bypass swallowing. C. Document swallowing trouble and continue diet. D. Reassure patient that swallowing improves later. Which would you go with? Lock it in before the reveal. The correct answer is A. Consult speech-language pathologist for swallow study. A is correct because a speech-language pathology consult fits a true collaborative intervention and brings expert evaluation of swallow safety. The pathologist guides diet texture and feeding strategies that prevent aspiration in the recovering stroke patient. B is wrong because placing a nasogastric tube requires a provider order and skipping the swallow workup over steps assessment. The team should evaluate swallowing first to determine whether oral intake can be made safe. C is wrong because charting alone leaves a high-risk situation unchanged. Continuing the current diet without a swallow evaluation puts the patient at serious risk for aspiration pneumonia, which the nurse must prevent through team referral. D is wrong because verbal reassurance does not address the danger of aspiration during the next meal. Comfort statements have value alongside action, but they cannot replace the formal swallow evaluation needed for safety. After a stroke, swallowing can become dangerously impaired, and recognizing this early is a critical nursing responsibility. The nurse looks for warning signs like coughing during meals, a wet voice after sips, drooling or pocketing food in the cheeks, and prolonged swallow time or unexplained weight loss. The most dangerous scenario is silent aspiration, where food or liquid enters the airway without any cough to warn the bedside nurse, making structured screening essential rather than optional. Speech-language pathologists use tools like video fluoroscopy to directly visualize the swallow, checking whether the airway is properly protected or whether food and liquid are entering the trachea. The nurse identifies a risk and holds oral intake, but the speech-language pathologist performs the formal evaluation, and together the team prevents aspiration pneumonia through safe, guided feeding. Question 31. A nurse caring for a stable adult patient with mild dehydration plans interventions. The patient is alert, cooperative, and tolerates oral fluids without nausea. The nurse selects the most appropriate first-line nursing measure to address the deficit before considering more invasive options for fluid replacement during the day. Your options are A. Restrict oral intake to small sips. B. Initiate intravenous fluids without an order. C. Avoid encouraging fluids until provider arrives. D. Encourage oral fluids and monitor intake. Don't overthink it. Which one feels right? The correct answer is D. Encourage oral fluids and monitor intake. D is correct because encouraging oral fluids and monitoring intake is the first-line approach for mild dehydration in an alert patient. The intervention is independent, safe, and effective when the patient can swallow without aspiration risk. A is wrong because restricting oral intake worsens dehydration and contradicts the basic plan of care. The patient needs more fluid, not less, and limiting intake without a clinical reason runs counter to standard nursing practice. B is wrong because initiating intravenous fluids without an order exceeds nursing scope of practice. The nurse may suggest fluids during communication, but the prescriber writes the order before any infusion can begin at the bedside. C is wrong because avoiding any encouragement until the provider arrives delays a safe and standard nursing intervention. Oral hydration is independent and well within nursing scope. Waiting for orders is unnecessary for routine encouragement of fluids. Oral hydration is the first-line nursing intervention for mild dehydration in alert patients who can safely swallow. It's an independent action, meaning the nurse can start it without a provider order, because it carries minimal risk when matched to the right patient. Dehydration is common in older adults, post-operative patients, and those with fever or GI losses. Oral fluids are the natural physiologic route, since the gut absorbs water and electrolytes well when intake is adequate. Intravenous fluids are saved for when oral intake is inadequate, contraindicated, or faster correction is needed. As the nurse offers small, frequent sips of water, broth, or oral rehydration solution, she watches for improvement, moister mucous membranes, better skin turgor, more frequent urination, and improved blood pressure. Urine output remains one of the most reliable measures of fluid status, so intake and output are both tracked closely. Watch for traps. Restricting fluids worsens dehydration. Starting intravenous fluids without an order exceeds nursing scope, and waiting for provider direction wrongly treats a routine independent action as if it needed one. Encouraging oral fluids is within nursing scope. Prescribing IV fluids belongs to the provider. Remember, when a patient is alert, can swallow, and shows mild dehydration, encouraging oral fluids is the nurse's independent first move. No order needed. Question 32. A nurse cares for a patient with constipation who has had no bowel movement for 4 days. The patient is on a high-fiber diet but reports straining and discomfort. The nurse considers the next safe intervention while waiting for further provider input on potential laxative or stool softener orders. Your options are: A. Restrict fluids to slow bowel motility. B. Encourage fluids and ambulation as tolerated. C. Insert finger to break impaction now. D. Wait several more days before action. Got a guess? Lock it in. The correct answer is B. Encourage fluids and ambulation as tolerated. B is correct because encouraging fluids and ambulation supports natural bowel function. Hydration softens stool and movement stimulates peristalsis, both of which help relieve constipation without invasive procedures or unprescribed medications during the patient's stay. A is wrong because restricting fluids worsens constipation by hardening stool further. Adequate hydration is foundational to bowel health, and reducing intake without specific reason directly contradicts standard nursing care for the constipated patient. C is wrong because manual disimpaction requires a provider order and assessment for impaction first. Reaching to break stool without confirmation and approval is outside standard nursing practice and could injure the rectum or trigger vagal response. D is wrong because waiting several more days without intervention allows constipation to worsen and potentially become impaction. The nurse should act on the cue now with non-invasive measures rather than letting the problem progress. Constipation happens when stool passage becomes infrequent, difficult, or incomplete, often with hard stools and straining. Risk factors include low fiber, dehydration, immobility, certain medications, and ignoring the urge to defecate, with older adults and hospitalized patients most vulnerable. Mechanically, the colon depends on water content, peristalsis, and reflex coordination. Dehydration produces hard stool. Immobility slows peristalsis, and ignoring the urge to go dampens the gastrocolic reflex over time. Each cause can be reversed at the bedside. Increased fluid softens stool, ambulation stimulates peristalsis, privacy and unhurried time support the natural reflex, and fiber adds bulk when fluids are sufficient. Laxatives and disimpaction come later and only with a provider order. Constipation is often confused with related problems. Fecal impaction is severe constipation with stool stuck in the rectum. ELIS is a functional shutdown of motility after surgery with distension and absent bowel sounds. And bowel obstruction is a mechanical blockage requiring emergency care. The exam trap is restricting fluids, performing disimpaction without an order, or simply waiting. Always start with fluids, mobility, and privacy. Escalate only with orders, and use assessment to tell constipation apart from impaction, ELIS, or obstruction. Question 33. A nurse encounters an ethical conflict between the family's wishes and the patient's documented preferences in end-of-life care. The team is unsure how to proceed. The nurse considers the appropriate action that supports the patient and team. Institutions have resources designed for these difficult situations. Your options are: A. Request consultation with ethics committee. B. Ignore conflict and proceed as family wishes. C. Make a personal decision to act unilaterally. D. Discuss case publicly to gain perspectives. Which one is it? Pause the video if you need more time. The correct answer is A. Request consultation with ethics committee is correct because ethics committees exist to help teams work through complex ethical conflicts. The committee gathers stakeholders, reviews the case, and offers guidance based on principles, policy, and law, supporting the team and the patient through difficult decisions. B is wrong because ignoring the conflict and proceeding as the family wishes overrides the patient's documented preferences. The nurse must advocate for the patient's expressed wishes and use institutional resources to navigate the disagreement appropriately. C is wrong because making a personal decision to act unilaterally bypasses the team and institutional safeguards. Ethical conflicts require collaboration and structured discussion, not solitary action by one team member, no matter how well-intentioned the choice seems. D is wrong because discussing the case publicly violates confidentiality and professional standards. The nurse uses formal channels like ethics committees rather than public discussion to address conflicts that involve specific patient information and decisions about care. When a clinical conflict can't be resolved at the bedside, hospitals turn to a structured resource built exactly for this moment, the ethics committee. The committee brings together physicians, nurses, social workers, chaplains, ethicists, and sometimes legal advisors, so no single voice can become entrenched in one position. The committee gathers facts, interviews the team and family, and weighs principles like autonomy, beneficence, non-maleficence, and justice to reach a recommendation, though the team keeps final authority to act. Picture a patient whose advance directive declines aggressive measures, while a family member insists on full code. The nurse advocates for the patient, escalates the conflict, and requests an ethics consult, which meets promptly and guides the team toward a recommendation aligned with the patient's directive. Don't confuse this with risk management, which handles liability, the institutional review board, which oversees research, or the legal department, which handles legal matters. The ethics committee alone deliberates on values and principles in clinical cares and unilateral action. Ignoring conflict or public discussion are always the wrong answer. Question 34. A nurse caring for a patient with new fever of 102 notes the patient is warm, slightly flushed, and reports mild discomfort. The nurse considers the appropriate initial nursing action while waiting for the provider to call back. The patient is alert and tolerating oral fluids. Your options are: A. Apply ice packs to all extremities. B. Give a cold soaking sponge bath. C. Encourage fluids and offer light cover. D. Keep patient bundled in warm blankets. Take a second. Which answer would you pick? The correct answer is C. Encourage fluids and offer light cover. C is correct because encouraging fluids supports increased metabolic demand during fever and replaces insensible losses. A light cover supports patient comfort while allowing heat dissipation, and the nurse continues to monitor the trend over the next hour. A is wrong because aggressive ice packs cause shivering, which raises core temperature further as muscles generate heat, The intervention is also uncomfortable and unnecessary for a moderate fever in an otherwise stable adult patient. B is wrong because a cold sponge bath also triggers shivering and undoes any cooling effect. Tepid water is sometimes used, but fluids and a light cover usually suffice for moderate fever in a stable adult. D is wrong because bundling the patient in warm blankets traps heat and elevates the temperature further. The intervention is the opposite of what the patient needs. Air circulation should be promoted, not blocked through heavy layers. Fever is not the body losing control. It's a deliberate reset of the hypothalamic set point, usually triggered by pyrogens, and the body actively works to reach that new temperature through shivering, vasoconstriction, and increased metabolism. Fever is like turning up the thermostat in a house. The furnace, or the body's metabolism, works hard to reach that new target, and once it gets there, it holds steady rather than spiraling out of control. Because fever is regulated, not chaotic, the thoughtful nursing response supports the patient rather than fighting the fever harshly. That means offering fluids, providing a light cover, monitoring vital sign trends, and giving antipyretics per order when comfort or safety calls for it. Mechanically, these two conditions are opposites. In fever, the hypothalamus itself resets higher, driven by pyrogens. In hypothermia, the set point never changes. The body's cooling system simply fails under environmental heat or extreme exertion. Because fever is regulated, it's supported with fluids, comfort, and antipyretics. Because hypothermia is a regulatory failure, it demands aggressive cooling. Knowing which one you're facing changes everything about the nursing response. Question 35. A nurse considers the difference between fever and hypothermia when caring for two patients with elevated temperatures. One patient has a clear infection and an inflammatory response, while the other was found in a hot car with rapid heat exposure. The nurse identifies the mechanism in the second patient. Your options are a hypothalamic set point reset higher, B. Thermoregulatory failure with environmental heat, C. Cytokine-mediated reset of temperature center, D. Pyrogen exposure from bacterial infection. Before I reveal it, which one do you think is right? The correct answer is B. Thermoregulatory failure with environmental heat. B is correct because hypothermia results from thermoregulatory failure under environmental heat, not a reset of the hypothalamic set point. Cooling is appropriate because the body is unable to dissipate heat fast enough on its own. A is wrong because a reset hypothalamic set point describes fever, where the body actively maintains a higher core temperature. The mechanism comes from inflammatory mediators, not the failure of thermoregulation seen in environmental heat exposure. C is wrong because cytokine-mediated reset of the temperature center describes fever, not hypothermia. Cytokines are produced as part of an immune response and cause the hypothalamus to push for a higher target temperature. D is wrong because pyrogen exposure from bacterial infection produces fever rather than hypothermia. The mechanism for the second patient is environmental heat, not a circulating pyrogen from an infectious source within the body. Hypothermia happens when the body's cooling system is overwhelmed by heat, not when the brain intentionally raises its temperature target. The hypothalamic set point stays normal, but core temperature climbs anyway because sweating, vasodilation, and faster breathing can't keep up. This distinction matters clinically. In fever, the set point is deliberately raised, so aggressive cooling just triggers shivering. In hypothermia, the body is already overwhelmed, so aggressive cooling is exactly what's needed. In heat stroke, ambient heat exceeds what sweating and vasodilation can handle. As the mechanism fails, sweating stops, skin turns dry and hot, and mental status changes. Seizures and organ damage can follow, all while the hypothalamus stays set at normal. Don't confuse general hypothermia with malignant hypothermia, a genetic anesthetic reaction treated with dantrolene, or thyroid storm, an endocrine emergency treated with anti-thyroid measures. Environmental hypothermia is treated with rapid cooling. The exam trap is explaining hypothermia with pyrogens or cytokines. That's fever's mechanism, not hypothermia's. Keep the model clear. A normal set point overwhelmed by heat calls for rapid cooling, not antipyretics. Question 36. A registered nurse on the medical surgical floor must complete several tasks during the shift. The nurse considers which task can be assigned to the unlicensed assistive personnel, since some require independent assessment and clinical judgment beyond the assistive personnel's scope of practice today. Your options are A. Recording vital signs on a stable patient, B. Teaching insulin self-injection to a patient, C. Performing an admission head-to-toe assessment, D. Adjusting an intravenous infusion rate. What's your answer? Commit to one before I continue. The correct answer is A. Recording vital signs on a stable patient. A is correct because recording vital signs on a stable patient sits squarely within unlicensed assistive personnel scope. The task is routine, predictable, and requires no nursing judgment, making it safe to delegate during the shift. B is wrong because teaching insulin self-injection requires the registered nurse because patient education involves assessment of learning, evaluation of return demonstration, and clinical judgment. Assistive personnel cannot perform that level of teaching. C is wrong because an admission head-to-toe assessment is a registered nurse responsibility that establishes baseline clinical data. The judgment and physical assessment skills required exceed unlicensed assistive personnel scope of practice anywhere. D is wrong because adjusting an intravenous infusion rate is a licensed nurse task, often a registered nurse one. Unlicensed personnel cannot manipulate medication delivery devices because errors carry serious patient safety consequences immediately. When a registered nurse hands off a task, accountability doesn't disappear. It stays with the nurse. The 5 rights of delegation exist to guide that decision safely. The 5 rights are right task, right circumstance, right person, right direction and communication, and right supervision and evaluation. Together they help the nurse decide what can be handed off and defend that decision if questioned. In practice, the nurse sorts tasks by scope. Routine, predictable work like vital signs on a stable patient goes to unlicensed assistive personnel, while assessment, teaching, and intravenous medication management stay with licensed nursing staff. Delegation is often confused with assignment or substitution. Assignment is simply giving a person their patient load, and substitution replaces one role with another. But delegation specifically transfers a task while the nurse keeps accountability for the outcome. Watch for options that delegate assessment, teaching, or judgment-based tasks like insulin teaching or intravenous adjustments. Those stay with the nurse. The framework is a balance. Delegate what fits, retain what does not. Question 37. A nurse receives a telephone order from the on-call provider for a new medication and dose. The unit policy requires a specific verification process to reduce errors caused by mishearing names, doses, or routes. The nurse considers the safest practice for the verbal exchange before charting and administering. Your options are A. Hang up and chart the order quickly, B. Ask another nurse to repeat to provider, C. Read back order to provider verbatim, D. Sign the order without further verification. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Read back order to provider verbatim. C is correct because reading the order back to the provider verbatim allows correction of misheard medications, doses, or routes. The structured readback is a verbal version of independent verification and prevents many telephone order medication errors. A is wrong because hanging up and charting quickly skips the verification needed for verbal orders. Without readback, mishearing a sound-alike drug name or wrong dose can become a serious medication error before anyone catches it. B is wrong because asking another nurse to repeat the order to the provider does not include the receiving nurse who will carry it out. The nurse who heard the order must read it back personally to confirm understanding. D is wrong because signing the order without verification eliminates the safety check entirely. Verbal orders carry higher risk for sound-alike confusion, so additional verification through readback is required by most facility policies. Telephone orders are verbal orders given by a provider to a nurse over the phone, and they carry higher risk of error than written or electronic orders, because there's no written or electronic record to check against. Errors like sound-alike drug names, accents, background noise, and the lack of visual confirmation make these orders especially dangerous, risking wrong drug, wrong dose, or wrong route. The nurse listens, writes the order down, and reads it back verbatim, including drug name, dose, route, and frequency. The provider confirms, the nurse signs and dates it as a telephone order, and the provider countersigns later. Exam traps include hanging up without verification, signing without checking, or asking another nurse to repeat the order back. Each defeats the safety check, because the receiving nurse who will administer the medication must personally confirm what they heard. Telephone orders demand personal readback because of their high error risk, unlike electronic orders, which need none, and in-person verbal orders, which carry only slightly less risk. Question 38. A registered nurse on a busy floor decides which tasks can be delegated to unlicensed assistive personnel. The nurse considers scope of practice. Some tasks require nursing assessment or judgment, while others are routine and predictable. The nurse selects a task that fits within the unlicensed assistive personnel scope safely. Your options are A. Perform an admission assessment. B. Initiate intravenous fluids on patient. C. Teach insulin self-injection technique. D. Take routine vital signs on stable patient. Which would you go with? Lock it in before the reveal. The correct answer is D. Take routine vital signs on stable patient. D is correct because routine vital signs on a stable patient fit within unlicensed assistive personnel scope. The task is predictable and does not require nursing judgment, so the nurse can delegate safely while remaining responsible for any abnormal findings reported. A is wrong because an admission assessment requires registered nurse level skills, including history, physical assessment, and care planning. The complexity exceeds unlicensed assistive personnel scope, and the registered nurse retains responsibility for that initial baseline evaluation. B is wrong because initiating intravenous fluids requires a licensed nurse and falls outside unlicensed assistive personnel scope. The skill involves judgment about access, fluid choice, and rate, none of which can be performed by unlicensed staff. C is wrong because teaching insulin self-injection is a registered nurse responsibility because it requires assessment of learning, return demonstration, and clinical judgment. Unlicensed personnel cannot perform that level of teaching for any patient on the unit. Delegation is how the registered nurse decides which tasks stay with them and which can safely go to other staff. It exists because nursing units cannot function without sharing work, but that sharing must always be safe. The nurse checks every task against 5 rights. Right task asks if it's appropriate to delegate at all. Right circumstance asks if the patient is stable. Right person asks if the assistant is trained. Right direction asks if instructions are clear. And right supervision asks if the nurse follows up. Picture a nurse with several patients, routine vital signs. Bathing and ambulation for stable patients go to unlicensed assistive personnel, while the nurse personally handles the admission assessment, insulin teaching, and adjusting an IV medication rate. The exam trap is any option that delegates assessment, teaching, or judgment requiring procedures, or hands-off intravenous medication administration and initiation, since these exceed what unlicensed assistive personnel can perform. Delegation, assignment, supervision, and abandonment are related but distinct concepts, and remembering that the registered nurse remains accountable for outcomes is the key to answering these questions correctly. Question 39. A nurse is preparing to administer intravenous potassium for a patient with hypokalemia. The nurse considers the high alert rules for the medication. Improper administration of intravenous potassium can cause cardiac arrest, so the nurse follows specific safety steps including rate, dilution, and monitoring during the infusion process. Your options are A. Never give intravenous potassium as a push. B. Push slowly over 15 seconds is fine. So bolus pushes are routine practice. D. Concentration and dilution rules do not apply. Don't overthink it. Which one feels right? The correct answer is A. Never give intravenous potassium as a push. A is correct because intravenous potassium is never given by direct push because rapid administration can cause fatal cardiac arrest. The nurse uses an infusion pump, follows dilution and rate limits, and monitors the patient during the entire infusion. B is wrong because pushing potassium over any duration is unsafe. The medication is given as a controlled infusion. The mistake is one of the most dangerous medication errors and is the reason the high alert rules exist. C is wrong because bolus pushes of potassium have no place in routine practice. The medication requires dilution, infusion pump delivery, and rate limits to prevent cardiac arrest in any patient receiving the medication. D is wrong because concentration and dilution rules apply strictly to intravenous potassium. The nurse must follow specific limits and avoid concentrated solutions outside specific monitored settings to keep the patient safe during therapy. Intravenous potassium is a high alert medication, meaning strict rules exist to prevent it from stopping the heart. Cardiac muscle depends on a precise balance of potassium inside and outside its cells. A rapid IV surge disrupts that balance, causing hyperkalemia that can stop the heart in cardiac arrest. So correction must always be controlled, never rapid. Safe administration always includes dilution to a maximum concentration, delivery through an infusion pump at a controlled rate, cardiac monitoring during faster infusions, and checking the site for vein irritation, since potassium is a known irritant. Picture the pathway. Diluted potassium flows from the bag through a rate-limiting pump into a peripheral or central line and quickly reaches the heart, which is why monitoring and rate limits matter so much. There is no safe slow push method for IV potassium. It must always be diluted and delivered by pump within strict rate limits, with the serum level rechecked afterward to confirm correction. Question 40. A nurse new to the unit is reviewing standard precautions during orientation. The nurse considers when standard precautions apply to patients during routine care. Standard precautions form the foundation of infection prevention regardless of suspected diagnosis or known infection status of any individual patient on the unit. Your options are A. Only when blood is visible. B. Only with confirmed isolation orders. C. Only during invasive procedures. D. Apply to every patient at all times. Got a guess? Lock it in. The correct answer is D. Apply to every patient at all times. D is correct because standard precautions apply to every patient regardless of diagnosis or suspected infection. The approach assumes any blood, body fluid, or non-intact skin can transmit infection and therefore guides every routine encounter. A is wrong because visible blood is one trigger but not the only one. Standard precautions apply continuously because invisible body fluids, mucous membrane contact, and skin breaks all create transmission opportunities throughout daily nursing tasks. B is wrong because standard precautions apply universally and do not depend on isolation orders. Transmission-based precautions are the additional layer ordered for known or suspected pathogens, but standard precautions form the constant baseline. C is wrong because invasive procedures require additional precautions, but standard precautions still apply during all routine care. Standard precautions cover hand hygiene, gloves, and other protections during everyday non-invasive activities at the bedside. Standard precautions are the foundation of infection prevention in healthcare. They assume any patient could carry a pathogen, so every blood, body fluid, non-intact skin, or mucous membrane contact is treated as a potential transmission risk, regardless of diagnosis. The framework exists because many patients with transmissible infections are unrecognized at the time of care. Hepatitis B, hepatitis C, and HIV can be present without obvious signs, so treating everyone as potentially infectious protects workers and patients while reducing stigma. Mechanically, this means hand hygiene before and after every contact, gloves when fluid contact is anticipated, gowns for soiling risk, masks and eye protection against splashing, and safe handling of equipment and linen. Hand hygiene remains the single most important practice of all. Standard precautions are sometimes confused with transmission-based precautions or surgical asepsis. Transmission-based precautions add protections for known pathogens, and surgical asepsis is sterile technique for invasive procedures. But standard precautions are the clean baseline applied to every single patient. The exam trap limits standard precautions to visible blood, isolation orders, or invasive procedures. Each creates dangerous gaps. Remember, standard precautions are the constant baseline with other protections layered on top. Question 41. A nurse is checking orthostatic vital signs for a patient with reported dizziness when standing. The nurse considers the proper sequence and timing for measurements. The patient is alert, has been resting in bed, and is willing to participate. The nurse selects the correct technique for the assessment now. Your options are A. Standing first, then sitting, then lying. B. Lying for 1 minute, sitting, then standing. C. Lying, then sitting, then standing with timing. D. Random positions taken without standardized timing. Which one is it? Pause the video if you need more time. The correct answer is C. Lying, then sitting, then standing with timing. C is correct because orthostatic vital signs are taken lying, then sitting, then standing, with brief delays between positions. A drop of 20 millimeters of mercury systolic or 10 diastolic or pulse rise of 20 is significant. I is wrong because starting with standing reverses the sequence and misses the lying baseline needed to compare. Without that baseline, the nurse cannot identify the drop that defines orthostatic hypertension during the assessment process. B is wrong because sitting before measuring, lying loses the resting reference point. Lying must be the first position so that subsequent readings can be compared with the patient at full rest in horizontal position. D is wrong because random positions and inconsistent timing make the measurement unreliable. Standardized sequence and pacing are needed for orthostatic vital signs to detect the drop in blood pressure on position change correctly. Orthostatic vital signs are a structured way to measure how blood pressure and pulse respond when a patient changes position, helping catch a dangerous drop before it causes a fall. The patient lies flat for several minutes for a baseline reading, then sits, then stands, with a 1 to 3 minute wait before each new reading. This time sequence is what lets the nurse reliably detect a true postural drop. A result counts as orthostatic hypertension if systolic pressure falls 20 millimeters of mercury, diastolic falls 10, or pulse rises 20 beats per minute. Normally, the body compensates for standing through reflex vasoconstriction and a faster heart rate. And when that compensation is delayed or insufficient, the patient becomes lightheaded. Normally, baroreceptors detect blood pooling in the legs upon standing and trigger reflex vasoconstriction and a faster heart rate to keep blood pressure stable. When this reflex fails, dehydration, blood loss, autonomic dysfunction, or medications are common culprits behind the drop. Watch for exam traps that reverse the order, skip the lying baseline, or drop the timed intervals. Without them, the drop can't be measured. The structured lying, sitting, standing sequence is the only reliable way to catch this pattern. Question 42. A nurse caring for several patients must decide which problem ranks highest. One patient reports loneliness, another has new chest pressure with diaphoresis, another has poor self-image, and another asks about future career planning. The nurse uses the Maslow and ABC frameworks together to prioritize action. Your options are A. Loneliness and need for social connection. B. Chest pressure with diaphoresis and concern. C. Negative self-image affecting daily mood. D. Career planning question after discharge. Take a second. Which answer would you pick? The correct answer is B. Chest pressure with diaphoresis and concern. B is correct because chest pressure with diaphoresis suggests a possible cardiac event, ranking highest under ABC priorities. Physiologic and acute circulatory threats always come before love, esteem, and self-actualization needs in patient prioritization. A is wrong because loneliness sits in the love and belonging tier of Maslow, far below physiologic emergencies. The need is real but does not threaten survival, so it cannot outrank possible cardiac symptoms in any patient. C is wrong because self-image concerns belong to the esteem layer of Maslow, addressed only after physiologic and safety needs are stable. The nurse cannot ethically place an esteem issue ahead of suspected cardiac compromise. D is wrong because career planning belongs to self-actualization, the highest tier of Maslow. Such concerns are valid but never override an active physiologic threat, since survival itself is required before pursuing higher goals. When a nurse is caring for several patients at once, two frameworks decide who gets attention first: ABC and Maslow's hierarchy of needs. Airway, breathing, and circulation always outrank every other concern. Within ABC itself, airway is checked first, breathing second, and circulation third. Beyond ABC, Maslow's hierarchy ranks physiologic needs highest, followed by safety, then love and belonging, then esteem and self-actualization. Acute cardiac symptoms sit at the top physiologic tier, so they outrank emotional or planning concerns. Picture a nurse with 4 patients, one lonely, one worried about self-image, one asking about career plans, and one with new chest pressure and diaphoresis. The nurse goes straight to the chest pressure patient, assesses, takes vital signs, and calls for help because that circulation problem threatens survival right now. Prioritization is the immediate judgment call about who to help first, not delegation or long-term care planning. When frameworks compete, the acute physiologic threat always wins over emotional or life planning concerns. Question 43. A nurse is measuring respirations on a patient who just settled into bed after a brief walk. The nurse considers the most accurate technique to count respiratory rate without altering the patient's breathing pattern through self-awareness during the count. The unit is quiet and the patient is comfortable. Your options are A. Tell the patient to breathe normally. B. Place a sensor on the lip carefully. C. Ask patient to follow nurse's breathing. D. Count chest rise quietly without telling. Before I reveal it, which one do you think is right? The correct answer is D. Count chest rise quietly without telling. D is correct because counting chest rise quietly without telling the patient prevents conscious alteration of the breathing rate. Patients often slow or speed up when they know respirations are being measured, which biases the recorded rate. A is wrong because telling the patient to breathe normally draws attention to breathing and changes the natural rate. The nurse should not announce the assessment, since awareness alters the very behavior being measured at the bedside. B is wrong because placing a sensor on the lip is unnecessary for routine bedside respiratory rate measurement. Visual counting of chest rise gives a reliable rate when the patient does not know the count is happening. C is wrong because asking the patient to follow the nurse's breathing imposes a rate rather than measuring the actual one. The number gathered will reflect the demonstration rather than the patient's true respiratory pattern at all. Respiratory rate must be measured without the patient knowing. The moment breathing becomes conscious, it stops being automatic. Once told to breathe normally, patients unconsciously speed up, slow down, or breathe more deliberately. The recorded number then reflects awareness, not the true autonomic baseline, which is why respiratory rate is so easy to distort and so valuable when measured correctly. The nurse takes the radial pulse, then keeps that same hand contact while quietly watching the chest rise. The patient assumes the pulse count continues, unaware that respirations are now being tracked for a full 30 or 60 seconds. The exam trap is any option that announces the assessment, asks the patient to follow the nurse's breathing, or attaches a sensor when none is needed. Each of these alters the natural rate instead of preserving it, unlike the quiet, unobtrusive count that captures the true pattern. This manual count still captures rate, depth, pattern, and effort in ways that pulse oximetry and capnography cannot replace. Skilled, unobtrusive counting remains one of nursing's most sensitive tools for catching deterioration early. Question 44. A nurse is performing a sterile dressing change and considers actions that constitute a break in sterile technique. The most important step in maintaining the field is awareness of common errors that quietly contaminate the field, even when the nurse believes everything is going well during the procedure. Your options are A. Turning back on field even briefly. B. Holding sterile items above waist. C. Opening packages with sterile sides up. D. Pouring solution without splashing on tray. What's your answer? Commit to one before I continue. The correct answer is A. Turning back on field even briefly. A is correct because turning the back on a sterile field contaminates it, even briefly, because the field is no longer monitored. Out of sight equals out of sterile, and the nurse must remain facing and watching the field at all times. B is wrong because holding sterile items above the waist preserves sterility, because anything below waist level is considered non-sterile. The action is correct technique, not a break, since visibility and elevation are both maintained. C is wrong because opening packages with the sterile inner surfaces facing up keeps the contents sterile during transfer. The technique is recommended rather than incorrect, and the wrapper edges fold away from the contents. D is wrong because pouring solution carefully without splashing keeps the tray dry and avoids strike-through contamination. The nurse demonstrates correct technique here rather than committing a break in sterility during fluid handling. Sterile technique creates and maintains a field completely free of microorganisms during procedures that bypass the body's normal barriers, like surgery, central line insertion, and catheterization. The core principles are simple but strict. always maintain visual contact with the field. Keep sterile items above waist level. Open packages so contents stay sterile. And pour solutions without splashing or letting sterile and non-sterile surfaces touch. Mechanically, the nurse opens sterile packages with the inner surfaces facing up, applies sterile gloves, and builds the field by keeping every item above waist level and in constant view, remaining facing the field the entire time. The classic exam trap is the option where the nurse turns her back on the field, even briefly, because losing sight of the field means losing control of its sterility. Unlike items dropping below waist level or packages opened incorrectly, which are more obvious breaks. Don't confuse sterile technique with clean technique, which only reduces microorganisms, or medical asepsis, which includes hand hygiene. Sterile technique alone aims for 0 microorganisms, and the nurse chooses the right level based on the procedure and body site involved. Question 45. A nurse caring for a patient on bed rest after surgery considers the complications of prolonged immobility. The patient has been still for several days, and the nurse plans interventions to prevent the most serious cardiopulmonary complication. Several systems are at risk during prolonged immobility, and the nurse prioritizes accordingly. Your options are A. Increased appetite and weight gain. B. Improved circulation in deep veins. C. Venous thromboembolism risk increase. D. Faster wound healing through rest. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Venous thromboembolism risk increase. C is correct because prolonged immobility raises the risk of venous thromboembolism through stasis in deep veins. The nurse uses sequential compression devices, encourages leg exercises, and ensures hydration to reduce clot formation during the recovery period. This is wrong because increased appetite and weight gain are not typical complications of prolonged immobility. Most immobile patients lose appetite and muscle mass, not gain weight, so the option misrepresents the actual physiologic effects observed. B is wrong because circulation in deep veins worsens, not improves, during immobility. Stasis sets up the conditions for clot formation, so the option describes the opposite of what really happens with prolonged bed rest. D is wrong because wound healing slows during immobility because of decreased perfusion and muscle wasting. Movement actually supports healing, while inactivity weakens tissue and prolongs recovery time after surgery and other procedures. Prolonged immobility doesn't just weaken muscles. It triggers predictable complications across every body system. And the most dangerous is venous thromboembolism. Bed rest affects the body all at once. Clots can form in the veins. Lungs can develop pneumonia or atelectasis. Skin breaks down into pressure injuries. Muscles waste and joints stiffen. The gut and bladder slow down, and bones lose density. Mechanically, clots form because of stasis, endothelial injury, and hypercoagulability. Without calf muscle contractions to pump blood back to the heart, blood pools in the deep veins, a clot forms, and it can break free and travel to the lungs as a pulmonary embolism. Prevention works in layers. Sequential compression devices mechanically mimic the muscle pump. Anticoagulants like low molecular weight heparin reduce hypercoagulability, and ankle pumps with early ambulation fight stasis directly. Exam writers love to disguise a wrong answer as an improvement. Increased appetite, better circulation, faster healing, but immobility only ever makes these worse, which is exactly why layered prevention matters. Question 46. A nurse uses barcode medication administration before giving a scheduled dose. The system scans the patient's wristband and the medication. The nurse considers a safety benefit. The technology adds another layer of verification on top of the rights and 3 checks already performed. Your options are: A. Replaces the need for any rights check. B. Catches wrong patient or drug at bedside. C. Eliminates need for two identifiers. D. Removes the need for nurse judgment. Which would you go with? Lock it in before the reveal. The correct answer is B. Catches wrong patient or drug at bedside. B is correct because barcode administration catches wrong patient and wrong drug errors at the point of care. The technology serves as a final electronic verification layered on top of the nurse's manual checks and clinical judgment about each dose. A is wrong because barcode administration adds to rather than replaces the rights of medication administration. The nurse continues to verify drug, dosage, route, and time using clinical judgment, with the scanner serving as a backup safety net. C is wrong because two identifier verification remains required even with barcode administration. The wristband provides one identifier, and the nurse confirms a second identifier verbally before each medication is given to the patient. D is wrong because barcode administration does not remove the need for nurse judgment. The nurse must still assess the patient, evaluate the indication, recognize unusual findings, and decide whether the medication is safe at the moment. Barcode medication administration adds an electronic safety check at the bedside, verifying the right patient and the right medication before a dose is given. The nurse scans the patient's wristband and the medication package, and the system compares both against the order, checking the medication, dose, and time before flagging any mismatch. The exam trap is thinking this technology replaces safety practices. It never does. The rights of administration, the 3 checks, the 2 identifiers, and clinical judgment all remain fully in place. Don't confuse this with related technologies. Medication reconciliation compares lists across care transitions, and smart pumps use drug libraries to limit infusion errors, while barcode administration is specifically the bedside scanning step, each addressing a different point of risk. The nurse still assesses the patient, evaluates the indication, and decides whether the medication is safe right now. The scan confirms the match. The nurse still makes the call. Question 47. A nurse considers torts that can occur in clinical practice. One tort involves the unauthorized physical touching of a patient, while another involves threats that create fear of harm. The nurse identifies the difference between assault and battery as legal terms in nursing practice and during care of patients. Your options are: A. Both terms describe the same action. B. Assault is touching without consent. C. Battery is unauthorized touching of a patient. D. Battery is only verbal threats made openly. Don't overthink it. Which one feels right? The correct answer is C. Battery is unauthorized touching of a patient. C is correct because battery is the unauthorized physical touching of a patient, while assault is the threat of harm that creates fear. Both are torts and can be committed during clinical care if consent is not obtained or coercion is used. It is wrong because assault and battery are distinct legal terms with different definitions. Treating them as the same misses the legal distinction that determines how the action is classified and the response that follows during a complaint. B is wrong because assault is the threat of harm rather than the touching itself. The action that creates fear without contact constitutes assault, and the touching that follows constitutes battery if no consent has been obtained. D is wrong because battery is the physical contact, not just verbal threats made openly. Verbal threats fall under assault, and the unauthorized touching that follows would constitute the additional tort of battery during care without consent. Assault and battery are 2 distinct intentional torts in healthcare, and nurses must be able to tell them apart. Assault is the threat of harmful or offensive contact that creates reasonable fear, even with no touching at all. Battery is the actual unauthorized touching, whether or not it causes harm. Both require intent, which sets them apart from negligence. Picture a confused patient refusing a blood draw. If the nurse threatens to call security and hold the patient down, that's assault. If the nurse actually restrains the patient to draw the blood anyway, battery is added on top. Exam traps often swap these terms or call battery a verbal threat, which is actually assault. Negligence is unintentional failure of duty, and false imprisonment is unauthorized confinement, both distinct from assault and battery. Consent must always be obtained before touching, refusal must be respected, and coercion has no place in care. When in doubt, pause, communicate, and document. Question 48. A nurse is teaching a patient before surgery about post-operative pulmonary care. The nurse considers the most effective topics to cover before surgery. Pre-op teaching reduces post-op pulmonary complications because the patient knows what to do and feels prepared rather than confused after waking up from anesthesia. Your options are A. Avoid moving for several days after surgery. B. Use incentive spirometer and deep breathing. C. Skip cough technique due to pain risk. D. Rely solely on nurse to perform exercises. Got a guess? Lock it in. The correct answer is B. Use incentive spirometer and deep breathing. B is correct because teaching incentive spirometer use, deep breathing, and coughing reduces atelectasis and pneumonia after surgery. Patients who learn these techniques before surgery use them more reliably while recovering and avoid common pulmonary complications during the hospital stay. Is wrong because avoiding movement for several days worsens pulmonary and circulatory complications. Early mobilization reduces atelectasis, pneumonia, and venous thromboembolism risk. So the teaching should encourage activity rather than prolonged immobility after surgery. C is wrong because skipping cough technique due to pain risk leaves the patient unable to clear secretions effectively. The nurse teaches splinting with a pillow and pairs analgesia with cough so the patient can perform the maneuver safely. D is wrong because relying solely on the nurse to perform exercises produces poor outcomes. Self-directed pulmonary hygiene is essential between nurse interactions, and the patient must own the practice to prevent complications throughout each day. Preoperative pulmonary teaching prepares patients to prevent breathing complications after surgery. Teaching before the procedure works better than teaching after because the patient is alert, comfortable, and able to practice without pain or sedation getting in the way. Postoperative pulmonary complications are common but largely preventable when patients breathe shallowly due to pain, sedation, and immobility. Alveoli collapse, secretions build up, and infection can follow. Active pulmonary hygiene reverses this whole process. Mechanically, the teaching covers 3 tools: the incentive spirometer, deep breathing, and effective coughing. For coughing, the patient splints the incision with a pillow to reduce pain, then produces 2 or 3 forceful coughs to clear secretions, practiced every hour while awake during early recovery. Watch for the exam trap. Avoiding movement worsens atelectasis and venous stasis. Skipping cough leaves secretions behind, and relying on the nurse alone is impossible to sustain hourly. The standard is self-directed exercises, taught in advance and supported with good pain control. Preoperative teaching sets the foundation, but the patient's own active participation, paired with adequate analgesia, is what actually protects the lungs after surgery. Question 49. A nurse is teaching a patient with right-sided weakness how to use a cane safely. The patient is alert and ready to learn. The nurse considers the correct hand for the cane and the gait sequence. Proper cane use reduces fall risk and supports the weaker limb. Your options are A. Hold cane in left hand opposite weak. B. Hold cane in right hand on weak. C. Switch hands every few steps. D. Hold cane behind the back during walking. Which one is it? Pause the video if you need more time. The correct answer is A. Hold cane in left hand opposite weak. A is correct because the cane is held in the hand opposite the weak side. With right-sided weakness, the cane goes in the left hand, advancing with the weak right leg to redistribute weight and improve stability. B is wrong because holding the cane on the same side as the weakness narrows the base of support. The body still leans toward the weak side and the cane cannot widen the base or share the load effectively. C is wrong because switching hands every few steps disrupts the gait pattern and adds confusion. The cane should remain on the strong side throughout walking so the patient can develop a steady, predictable pattern of movement. D is wrong because holding the cane behind the back removes any support function it provides. The cane works only when planted at the side and slightly forward to bear weight as the weak leg moves through. Correct cane use depends on simple biomechanics. The cane goes in the hand opposite the weak side, widening the base of support and taking weight off the weak leg. Held on the opposite side, the cane widens the base of support like a tripod, so the strong leg and the cane together keep the body stable while the weak leg swings through. In practice, the cane and the weak leg move forward together. Weight shifts onto the cane as the weak leg swings, and then the strong leg steps through on its own, producing a smooth, sustainable gait. Exam traps place the cane on the weak side, which narrows the base instead of widening it, or have the patient switch hands, or hold the cane behind the back where it can't bear weight when needed. Whenever you see cane use tested, confirm it's held opposite the weak side, advances with the weak leg, and stays in one consistent hand throughout the gait cycle. Question 50. A nurse instructs a same-day surgery patient about safety after going home. The patient received general anesthesia and is ready for discharge. The nurse considers the most important safety guidance that addresses the residual effects of anesthesia in the first day after the procedure. Your options are A. Drive home after the procedure alone. B. Sign legal documents on the day. C. Operate complex machinery the same day. D. Have responsible adult drive and stay. Take a second. Which answer would you pick? The correct answer is D. Have responsible adult drive and stay. D is correct because a responsible adult should drive the patient home and stay overnight after general anesthesia. The patient avoids driving, signing legal documents, and operating complex machinery for at least 24 hours due to residual sedation and impaired judgment. A is wrong because driving home after general anesthesia is unsafe because of residual sedation and slowed reflexes. The patient cannot legally drive while under the lingering effects, and arranging a ride home is part of standard pre-op planning. B is wrong because signing legal documents on the day is not advised because judgment may be impaired by anesthesia. Important decisions should wait until full mental clarity returns, typically the next day or later, depending on individual recovery. C is wrong because operating complex machinery the same day is dangerous, given residual anesthesia effects. The patient should rest and avoid tasks requiring sharp coordination or judgment until cleared and feeling fully recovered the next day. General anesthesia leaves the body long after a patient wakes up feeling normal. Discharge teaching exists to protect patients during that hidden window of risk. Anesthesia causes sedation, impaired judgment, slowed reflexes, and possible memory issues that linger well beyond the recovery unit. Patients often feel mostly normal, even though these effects are still active. For at least 24 hours, the patient avoids driving, signing legal documents, drinking alcohol, and operating complex machinery. A responsible adult must drive the patient home and stay overnight to help with basic tasks. The nurse confirms a responsible adult is present, reviews written instructions covering who to call and what symptoms to watch for, and walks through the 24-hour restrictions verbally. This safety net is what makes same-day surgery possible. Any answer choice that lets the patient drive, sign documents, or run machinery the same day is the trap. The safe choice always includes a responsible adult driver and overnight supervision. That brings today's HESI Fundamentals review to a close. If you're looking for more practice, our website offers hundreds of free questions along with complete detailed study guides just waiting for you to explore. Don't miss this opportunity. Simply follow the link in the description below to get started and begin learning today, right at your own pace. Subscribe and stay tuned for the next part. Good luck on your exam.